Well, it is now 12 p.m. Eastern time, 7 a.m. Hawaii time, and all. I think we should get started. And Kiawe, I'm glad we have you on now, ready to go. So first of all, I just wanted to, I think we should, welcome everybody to this workshop on research on Native Hawaiian and Pacific Islander health. I'm really excited to have so many people here, so many esteemed colleagues and researchers as well as community advocates. Before we get started, I do want to introduce Dr. Kiawe Kaholo Kukula to help us get started. So I'll pass that baton to you, Kiawe.
Mahalo. Could I please have screen sharing capabilities?
O au no veo ula kapua ke ali I po lena ha lena I te vai. Le ai te o kalu nu a ka uki. No pu ka uki o ka maka o ke ko ole. Ku vai hine pua ka ia ulu o lalo o lalo ki vai akana ulu. I ka hime ki una, e maka una. Me he haila ka pili o e wa he mai. E tomo mai, e tomo mai, e tomo mai naka maulu ki o manu nui a akea. Mai ka hea maka akau, mai ka hikina ki komohana. Mai na moku nui, moku iki, moku loa, moku poko. Mai na la hui kaulana I ho'o hui ia e ka moana nui a akea. Ue kalani nau e tahunu. Ola I ka honua, ho ola ka honua. Kuo te wairua tutupuna, kūpa ake kanaka mauli. Ki he mauli ola. Mahalo.
Thank you so much, Kiawe. And I wanted to again welcome everybody to this research on Native Hawaiian and Pacific Islander health workshop. I'm going to give a few opening remarks before I pass it on. Just so give me a moment to share my slides. Please let me know if this is.
You need in presenter mode.
Is it?
This looks like older version.
Hmm?
Or I don't know.
I believe it is.
Okay, keep going.
Okay. Well, first of all, I wanted to welcome everybody. My name is Gabriel Lai, and I am a program director in the Division of Integrative Biological and Behavioral Sciences here at the National Institute on Minority Health and Health Disparities. I really wanted to again welcome everybody here and just convey my enthusiasm and my joy and my thrill for having you all join us here this morning and this afternoon, wherever you are. This is just to give you an overview of this workshop. So overall, the objectives of this workshop are as follows: to identify the critical health outcomes and topics and needs affecting Native Hawaiian Pacific Islander communities, or as I'll just shorten it, NHPI, the current gaps in knowledge and research efforts on NHPI health outcomes, and future opportunities for research on promoting NHPI health to reduce health disparities. And really one of the overall objectives is to help us at the NIH to just consider and generate key recommendations for future research directions on Native Hawaiian and Pacific Islander health. So a number of factors motivated us at the NIH to organize this workshop. We recognize in the literature that very few studies focused on Native Hawaiian and Pacific Islander populations. And among those that did include NHPI populations, very often these populations primarily had Asian Americans and Native Hawaiians and Pacific Islanders aggregated together, and often they focused primarily on Asian Americans. Among those that did focus or have specific focus and exist on NHPI populations, those existing studies typically reported a small sample size. And then there were a lot of challenges in observing any associations, trends, or significant findings. And among studies or surveys that have looked at NHPI populations, often it's reported that these populations experience a higher burden for chronic disease and comorbidities compared with Asian American subgroups and many other racial and ethnic groups. As an example, within Hawaii, a study by the Hawaii State Department reported that Native Hawaiians had among the lowest life expectancy among all the racial groups. And we recognize that among many of these studies, little research was done on the social determinants of health or impact on intergenerational trauma, migration, or structural factors. And the conclusion is that essentially that the cause of health disparities was not extensively examined. And last year, we presented a concept advocating for research to understand and address health disparities in Native Hawaiian and Pacific Island populations. And it was certainly welcome and received enthusiastically. And at the same time, internally, we realized that it was important to have conversations with the research community to understand if there were specific topics or gaps in knowledge and research efforts on Native Hawaiian and Pacific Islander health. So what are the expectations of this workshop? Well, it's essentially to, well, sorry. Our expectations are for you to engage and to discuss and interact. And essentially, we hope that we could enhance the understanding of the state of the science of research on NHPI health and health disparities, to share preliminary research findings where available, and to identify gaps, and to share community strengths, best practices, and perspectives from Native Hawaiian and Pacific Islander populations, to share and discuss those approaches and tools and best practices to enable appropriate and culturally relevant research methods for Native Hawaiian and Pacific Islander populations. You know, we made a particular effort to invite researchers and Pacific Islander advocates, community advocates who identify and or work with Native Hawaiian and Pacific Islander communities so as to recognize the diversity of these communities. And our hope is that we can identify gaps, opportunities, and future research directions to understand NHPI health and eliminate disparities. So these are some of our key meeting questions, such as what are the known gaps in our knowledge of the causes and contributors to NHPI health and health disparities? What are the greatest challenges and opportunities for scientific advancement in the field of NHPI health? What are these unique strategies, tools, and data sets necessary to conduct NHPI health research? And how can we best address the greatest scientific and research challenges facing the field of NHPI health? So this workshop is divided into 4 specific sessions as listed here: the determinants of NHPI health, the mechanisms and processes, the methodological approaches and tools, and the cultural interventions that can improve NHPI health. There's also a specific breakout session at the end of this day. So today we'll be going over the first 2 sessions, while tomorrow we will go over the 3rd and 4th session. And really the breakout session that happens at the end of today, following session 2, will go on and give people an opportunity to discuss in more detail and in a free-flowing manner about each of these specific topics. Some housekeeping instructions. We ask that the speakers will maintain a certain time limit. As you know, there will be a chime, and this chime will take place approximately for those who are generally presenting in your respective sessions. There will be 2 minutes prior to the end, and then a final one. Mark, could you just put in that chime just so here? Thank you. So that's the chime that you'll hear, just to give you an indication. We will also ask for those who are not speaking to mute your audio and to close your video, and to only turn it on when you are speaking or actively participate during the discussion. And we ask all the participants to enter your questions in the Q&A box. And this is for those who are active speakers and discussants, but we also welcome questions and comments from the larger audience. And we will, at times when we can, look at those and bring that up in the conversations. For any technical issues, we ask you to contact Mark Gifford from CITEM at this following email: nimhdevents@citemgroup.com. This workshop isn't possible without the work of so many, and I want to acknowledge our co-chairs, Dr. Kiawe Kaholokula and Dr. Michael Spencer, and my many NIH and HHS colleagues here listed here. This was truly a community effort, and I really want to acknowledge everyone here and just convey how much I appreciate them. And that really ends my part. I just want to now introduce our NMHD director, Dr. Eliseo Perez Estapol, who's been supportive of this area of research on NHPI health. And before joining NMHD, Dr. Perez Estapol practiced general internal medicine for many years at the University of California, San Francisco, before moving to NIH in September 2015. And he was professor of medicine at UCSF and chief of the Division of General Internal Medicine for 17 years. And his research interests include improving the health of racial and ethnic minorities and underserved populations, advancing patient-centered care, improving cross-cultural communication skills among clinicians, and promoting diversity in the biomedical workforce. He has published countless number of peer-reviewed articles and has been acknowledged for his efforts. And I want you all to please join me in welcoming Dr. Eliseo Perez Estapol.
Thank you so much, Gabe, and I really especially want to thank Yahweh and Michael for co-chairing, and all the staff that I've worked with Gabe that he listed before, especially Rena Das. I also want to send a special welcome to our colleagues and friends in Hawaii, since we know how early it is there. Let me make sure my light is on here. Can I share my screen, or do you have the slides?
I have them ready if you want me to share them. It's up to you.
All right,
Got it.
I'll share them. And are they visible? Oh, use slideshow. Okay. So I'm just going to say a few words of things I have shared in other fora. I think this workshop is really important for many reasons. First, it's a minority population that's small and has not been properly identified and studied outside of some regional studies. And I salute those of you who have really led the charge on this. It's a critically important distinction because the health profile differs from the group that it has been usually been categorized with, which are Asians. The history of this goes back to beginning an OMB directive in 1997, when it was recognized that Pacific Islanders and Native Hawaiians, as the name is been labeled by the Office of Management and Budget, is a different race from Asians. However, it took 20 years for that to actually be implemented, in part because each state had to create their own system to be able to identify separately from Asian, and that wasn't completed until 2017. And second, there was a residual category of, quote, other Asian and Pacific Islander under the year 2011. We now have prospectively been collecting data on mortality, and life expectancy can be calculated separately for Pacific Islanders and Native Hawaiians. Now, when will that actually be done, completed by either the CDC or other groups will depend. The estimated total population based on the 2020 census was about 700,000 people, compared to something like 19 million people who are categorized as Asians. Most Native Hawaiian Pacific Islanders live in those 4 states that are listed there, with particularly the Marshallese community in Arkansas. So for my assessment of thinking about this, what are the sort of priority health issues as we see them from a public health perspective? We're pretty certain that overall mortality is probably higher than Asians. Unclear if this is different rates of disease, although that's likely for some conditions, also less access and later presentation for some conditions that could be treated earlier. There were clearly regional disparities from COVID disease reported from both California and Hawaii early in the pandemic. And the last CDC data that was reported on mortality for 2020, 21, and 2022 showed the separate calculation for Native Hawaiian Pacific Islanders and it being considerably higher than Asians for sure, in the same ballpark as the other racialized minority groups that had disproportionate burden of COVID-19 mortality. All went down in 2022, and final figures for 2023 will almost certainly continue to show a decrease. Hepatitis B and chronic liver disease and the consequence of liver cancer are more frequent in persons who are from Native Hawaiian Pacific Islander background. Diabetes related to high body mass index or obesity are also more common. I also would add stomach cancer is higher, and overall cancer mortality is higher. And I'll show you in an analysis done by NCI's intramural group in the past year. In this slide, this is age adjusted per 100,000, and it includes data from 2018 through 2020. And it shows, and just call your attention down here to Native Hawaiian Pacific Islander, if you wish to compare to all others, but also to Asians, you can see the overall mortality from cancer is much higher compared to Asians, and in fact, is second to Blacks and whites. I don't show the American Indian Alaska Native here because of room. Females are have a higher risk of overall risk of dying from cancer if you're Native Hawaiian Pacific Islanders than males. And then you can see the rates for the most common cancers, lung, breast, and prostate. You can see the breast cancer is second highest, and for prostate, it is in the ballpark as it is for whites. And this health profile for Native Hawaiian Pacific Islanders is overall worse, and the needs are misaligned if we continue to aggregate under the Asian population. This should always be challenged. And if anything, if it's, oh, we can't separate the data, then just call it Asian with an explanation as to why we're not calling it AAPI or whatever other acronym people are using. Important topic is also process of care. And in this way, there are perhaps more similarities with Asian Americans than not. There is lower screening rates for cancer, the screenable cancers, both breast and colorectal and cervical. Managing mental health is more challenging in many ways. This, although generally true for all racial and ethnic minority groups, Asian Americans and Native Hawaiian Pacific Islanders have greater challenges in the management of mental health issues. Language barriers may be significant, and there is rare, fairly uncommon to have clinician concordance. General reports from healthcare system studies show that quality of care is perceived to be worse, and patients are generally less satisfied. This has not been thoroughly explored as to why. There's the effect of the migration experience, which is somewhat different for Native Hawaiians and Pacific Islanders. And then discrimination and racism is real, as we understand, although people still question that. This is a study from the NMHD intramural program that was published around the time, data was collected around the time the vaccine was becoming available. And it was COVID-related discrimination in this minoritized groups in a nationally representative sample of an online survey. And we can see that there was a sufficient sample to collect on Hawaiian Pacific Islanders. The rates were much higher than for whites. The highest rate of perceived or reported discrimination was among Asian Americans. We remember with that. So I'll end with just a comment about research funding. It is still very, very infrequent. In our institute, we calculated about 8% of our awards had a topic on Native Hawaiian Pacific Islander health. I'll, shout out to the PIs in Hawaii who have been doing this research, also to our research centers for minority institutions, a grant that is at the University of Hawaii. As far as principal investigators who are of NHPI background, very few, 0.1% of all R1s for all of NIH are NHPI, and at NMHD, we don't do much better. There are one or two NHPI principal investigators at any given time. The SEAL initiative, the Community Engagement Alliance, that initially was focused exclusively on COVID and is now pivoting to other topics, has a good, an excellent Native Hawaiian Pacific Islander interest group that is developed nicely. And so I'd like to highlight that as well. And we had a number of RADx, rapid acceleration diagnostics for underserved population projects that focused on this population. So I want to thank you again for organizing this workshop. I look forward to attending as much as I can over the next day or so. Thank you, Gabe.
Thank you so much, Eliseo. And now we're going to move in to have welcome remarks from our esteemed co-chairs. And I'm first going to introduce Dr. Keawe Kaholokula. And Dr. Keawe Kaholokula is a professor and chair of Native Hawaiian Health at the John A. Burns School of Medicine, University of Hawaii at Manoa. And he's a clinical health psychologist and translational behavioral scientist with nearly 20 years of experience leading multiple federally funded community-engaged research projects aiming at improving NHPI health. And this research and advocacy have led to a number of systemic improvements in healthcare delivery, clinical outcomes, and policy for Native Hawaiian Pacific Islanders. Keawe?
Mahalo. Talofa lava, malo elelei, whakatalofa atu, I ora na, ki ora, ni sabula, afade, keselelie, yakwe, aloha mai. Greetings and welcome to all of you, our distinguished speakers and discussants, NIH colleagues, and the hundreds of people who are joining us remotely. We come together as Pacifica, Native Hawaiians and Pacific Islanders, and researchers who serve our Pacifica communities in our island homes in the Pacific, as well as across the diaspora. We come together to accelerate our progress toward health equity to achieve Mauli'ola, optimal health and well-being, for all our Pacifica communities. Although we are diverse, representing different languages, customs, and aspirations, we also share many commonalities, such as connected ancestry, love for our island homes and places we call home, and interdependence among our ohana, family, friends, and communities. Our communities also share the same disturbing health statistics and social circumstances that you heard earlier from Dr. Perez Stable. My Hispanic is not too good at color, my Stable. And this is mostly due to colonization, exploitation, and degradation of our cultural and natural resources. Also due to historical trauma and racism, as also pointed out, that adversely impact our Mauli'ola. In this two-day workshop, we will share the state of the science and the community engagement, our best and promising practices, gaps in knowledge, and our challenges and opportunities as Pacifica, so that we can help our NIH colleagues understand the kinds of research and implementation strategies necessary for our communities to achieve health equity. The mele or chant I offered to open this workshop paid homage to the arrival of a new day. And in metaphoric terms, it told of how the light from the rising sun uncovers those things previously hidden by the darkness, how it brings renewed life and enlightenment, and how it offers us the opportunity to heal and thrive. It is indeed a new dawn for Pacifica, as the light is now upon us. So mahalo to all of you for participating.
Thank you, Keawe. And I have the pleasure of introducing Dr. Michael Spencer, who is a professor and Balmer Endowed Dean in Social Work at the University of Washington. And he's the first Native Hawaiian Dean at the University of Washington. And he recently served as Director of Native Hawaiian, Pacific Islander, and Oceanic Affairs at the Indigenous Wellness Research Institute, a UW School of Social Work-based research center. And his research examines health and wellness among Native Hawaiian and Pacific Islanders, focusing on interventions that promote health among Native Hawaiians through Indigenous practice and values. Mike?
Aloha and welcome everyone to this wonderful research workshop on Native Hawaiian and Pacific Islanders. Thank you so much to NIMHD for sponsoring this for us. I'm delighted to be a part of this important gathering focused on advancing research efforts within the Pacifica communities. This workshop serves as a platform to foster collaboration, exchange ideas, develop strategies to address health disparities, and promote wellness among our communities. For years, our communities have either been left out of research, included in aggregate, or marginally included. In recent years, there's been an insurgence of interest in not only better understanding the health of our communities, but disentangling the aggregated data, developing new methods, dealing with the complexities of context, recalling epistemological wisdom of our ancestors, designing culturally grounded interventions that focus on our well-being, and looking at the resilience of our populations as we enter this new world. Throughout this workshop, we aim to cultivate a supportive environment where researchers, community leaders, and stakeholders can share insights, best practices, and innovative approaches to improve health outcomes and achieve health equity. Together, I hope we can harness the power of research and collective action to make meaningful strides towards improving the health and well-being of our Pacifica communities. Mahalo to my co-chair, Keave, for your wonderful insights and for your wonderful opening protocol. Thank you so much. Mahalo to our speakers and our discussants. Again, to NIH for sponsoring this event. And finally, to all of you for joining us on this important journey of discovery and empowerment. Mahalo.
Thank you so much, Mike, and thank you, Keave, again for those remarks. We are now going to be transitioning over to our keynote addresses, and I have the pleasure of introducing three distinguished speakers. First, for consideration of time, I plan to introduce all three, and then have all three of them transition over. The first I will wish to introduce is Dr. Nia Aye Ta'oto. She is the interim executive director.
Can we have the slide for the speakers?
Yes, I believe she's just put them on. She's about to get on. She's the interim executive director of the National Association of Pacifica Organizations, lead consultant to the Pacific Islander Center of Primary Care Excellence, a health equity arm of the Association of Asian Pacific Community Health Organization, and an adjunct associate professor at the University of Utah College of Health and the University of Hawaii John A. Burns School of Medicine. Her research interest is in the area of culturally centered diabetes prevention and management. And we also have two other community keynote speakers, Puni Kekauoha. Puni has been serving the Papakolea Hawaiian Homestead region since 1992, and she's currently the senior vice president of the Kula Nona Poe Hawaii, or Kula. Kula is a Native Hawaiian beneficiary serving organization that exists to promote cultural, education, environment, and health equity for all. And then we also have Ms. Paige Castro-Reyes. Paige is the Deputy Director of Community Campus Partnerships for Health, a national nonprofit that promotes health equity and social justice through community institutional partnerships. During her years at CCPH, she has served and supported multiple multi-partner projects focused on community engagement, community-led research ethics review, and culturally responsive research practices. And I wanted to indicate that, we specifically invited two community advocates from the different Native Hawaiian Pacific Islander who represent the different Native Hawaiian Pacific Islander communities and acknowledgement of the diversity of these communities. And then now pass it on to Nia. Nia, the floor is yours. Oh, I think you just had the presentation on.
Could you give Nia, could you give us sharing abilities here?
You have the ability to share.
Okay, thank you.
And Nia, for you specifically, the chime will be for 5 minutes before, and then the ending chime, just to give you a heads up.
Perfect.
Can you see what's on the screen?
Yes, we can.
Okay, we can see it. So first of all, I would like to acknowledge my privilege to be here and to represent researchers for Native Hawaiian Pacific Islander. When I received the invitation, I was kind of shocked because I don't really consider myself a researcher, because as a Pacifica person, we continue to seek knowledge in everywhere that we go, and places and spaces. So but it's indeed an honor. So wait, the thing, it's not working. It's not moving. I'm sharing office with Keave because it's like I was in Arkansas. I just landed in Hawaii 2 minutes ago. Okay. advancing now.
Sorry, everyone, we need technical difficulty here.
Should they just, okay, just enter?
Yep.
So for Pacifica people, it's hard to define research and what we're looking for. So I look into our indigenous language to define and understand research. So today I'm going to privilege the Samoan language. I identify as a Samoan Pacifica person. So the word that I use is tofa sa'ili. Tofa is wisdom and sa'ili is to search. Tofa sa'ili means man reaching out and examining within oneself for wisdom, knowledge, prudence, insights, and judgment through, that's our method, reflection, meditation, prayer, dialogue, experiment, practice, performance, and observance. This definition is very, very important to us Pacifica people because research is personal, is collective, is spiritual, is physical, and it's highly emotional. So it's very, very hard to stay within academia and do research on the Western sense, knowing that our definition is very broad and wide. There are other, so Tofasa Ili is the definition of research is to search for wisdom, but there's other way to look at wisdom, right? So in a Samoan language, there's Tofa Manino, wisdom that you receive by getting clarity. Manino is to be clear and clarity. There's also Tofa Loloto, is the wisdom that you receive by dive deep into issues and dive deep into yourself to figure out what's going on. And there's Tofa Mamao, is wisdom that you received by understanding that there is a future. You have to look out in the horizon and find wisdom from there. So it's hard to define research or seeking wisdom in just a one-dimensional area. So I always look at it as going fishing, something that is very familiar to us Pacifica people. You know, good day at fish. When you're fishing, it's good to have clear waters. So here is the water of Pilau. It's good to see the bottom of the water. You can see, the fish from there. It's also important to look deep down to follow Loto, because a lot of great fish, octopus, and things like that, you can't see it from the top. So you got to go deeper into the water to find it. But then there's also Tofa Mamao. This is very important because a lot of great fish and, in the Pacific is out way in the ocean. So you have to look out that way. And there's also a tradition in the Pacific when fishermen and folks are out in the water, we go up on a mountain and then also light a fire because we can use the smoke to guide you and where you're going. So it's very important then for us to consider all of these things. And there's a lot more Tofa, but I'll just cover these three. So in Tofa Manino, in clarity, it's important that we understand that we are people of the ocean. So even though in many conversation, in academia, in research, and even in community, we focus on the US Pacific, but it's important to remember that we are people of the ocean. We are represent Micronesia, Polynesia, and Melanesia. So that is Tofa Manino. I'm very clear of that. It's also important that I understand my Fa'asinomanga. This word is very similar to the kuleana, the hu'olelo kuleana, ikaolelo Hawaii. Fa'asinomanga is our responsibility, but that's a very limited definition also because fa'asinomanga, the word here, fa'asino is to point out and then also to guide. So who pointed out this responsibility to me and then who is explaining and guide me through it? So in order for me to do my research, I need to know my fa'asinomanga, my kuleana, and my responsibility and obligation to community. And I feel like this is one of the reasons why I decided to be placed in community. I'm still a researcher, I partner with a lot of researchers, but I want my community to be part of my journey, but I also want to be accountable to my community. So that is my Fa'asinomanga. Part of my Fa'asinomanga as a Samoan and a Pacifica person is I need to understand my language, my culture, my customs, my traditions, And I also need to understand our spiritual beliefs. So that is a Fasinamanga. History is very important to a specific people. So that will be something that I'll talk about, you know, throughout my presentation. So in reflection, and I'm a historian by hobby. I love to know more about where we come from, Pacifica people. So we all have legends, you know, we do follow oral tradition, but, you know, we're also visual people. So in looking at pictures from pre-colonization, you know, and we're also one of the last group to get colonized on Earth, right? So if you look at it, I think some of the pictures that I to look at is from this area in the Carolinians. In the early 1800s, a lot of Russians and French sailors were around the area, and they start drawing who we are. And it's not just in that area, in Hawaii, also in Samoa. Our pictures we're very lean, we're very physically strong. And they also comment on the way that we carry ourselves. So it's very interesting when I also look through journals and diaries and things, they often describe us Pacifica people as dignified and self-confident. I also want to reflect on it because when was the last time as a Pacifica person, or even as an outside person, look at Pacific people as dignified and self-confident? What happened? Who took our confidence? Who took our dignity? So we have to look at that, you know, even though you do have your research questions that you need to answer, things that you look for, but you got to follow to also look at who we are as a people. And in colonization, so as I mentioned earlier, we're the latest group on Earth to get colonized. So our colonization experience started in like the 1700s, 1600s. It was formally colonized in the late 1700s and 1800s. And if you look at health and colonization, one of the earliest acts of colonization that affects our health is the treatment of our traditional healers. So this picture of Palauan traditional healers, they were taken from Palau to Saipan, and same thing happened in Samoa also. So, and then all over the Pacifica, because they understand people who are charged to do healings, not only do healing of our body, but our spirit, our mind, and they were excommunicated because they feel that they should not be in charge of and taking care of our health, because this is also around the same time where clinics were introduced, the Western knowledge around medicine, healing, and then health. So if you really look at the history of Pacifica people, colonization, the effects of colonization started, you know, around that area, and along the same line, and then on into all the way up until the 1940s. You know, and that was also our history of militarization. So if you look at it in Kwajalein Atoll, you know, that's the introduction of a lot of imported food, right? So there was imported food at that time were like a luxury, it's very few. But I think around the 1940s and during war, we do also have a war narrative. During the war, a lot of the foods were brought in because of the destructions of our land. You know, a lot of the things were not growing because that's through the bombing throughout Northern Pacific. And similar situation was also happening in the South Pacific. But all of these things, the treatment of our healers, and then also our healing knowledge, and the importation of a lot of outside food, and also of outside influence into our community, that had effect of us that even up to now, we're trying to figure out, you know, how to move forward and then what to do. But also remember that, you know, in the beginning part of colonization and then militarization, there was a survey that was conducted by the US Navy. And they found intestinal parasites, yaws, TB, and other forms of skin diseases, complete absence of malnutrition or obesity, no indication of diabetes, and almost no hypertension. So it's very interesting that even then, that our people made it all the way up to that point into the 1940s. 1940s is not that far. You know, it's still less than 100 years, you know, ago, but yet we came so far and so quickly. And in colonization, so I'm gonna then focus from all of Pacifica into the USAPI and in the US. Every time we talk about colonization, I always get comments like, we're all colonized, all people were colonized and things like that. But within the context of the United States, I'm talking about people that were colonized by the United States. So there's a difference there, as young people say, it hits differently, right? When you're colonized by the people that you're still here, with us. So there's an extra responsibility or kuleana for Pacifica researcher to consider all of that when you're doing our research. So first, the way that we look at the Pacific, we have the US Pacific, folks that are in the Northern Pacific and South Pacific in American Samoa, but then also folks in the continent. So the way that we look at the Northern Pacific, we do have US territories and then the Kofa Nation because of their relationship with the United States. So in the territory, there's high militarization of the Pacific. I was just in Guam last week. They're doing, exercises there and things like that. But there's also, we have, the highest number per capita of people serving the military. We do love, adore, and appreciate all of our veterans, not just from the USAPI or the Pacific, but all over, people that are sacrificing their lives so that we can live freely in our country. But we also have the same situation in Kofa Nation, the Compact of Free Association. So that's where the bomb was tested in the Marshall Islands. It actually affects all of Micronesia, military bases, and then the FSM also have high volunteer and then also high military service folks. So looking at those two things, it also affects our health. So veterans health is something that we are, as researcher, are very interested in, not because it affects our veterans, but also their family. We're also looking at research around the narrative of colonization, but also narrative colonization and militarization. How does that impact of our health and then well-being? But with that in the USAPI, then we move on to the US, right? So if you look at it, migration, diaspora, a lot more are moving towards the continental US. I think this is the first census that we know that there are more Native Hawaiian living outside of Hawaii than in our homeland, but also in the USAPI, more and more are moving to the US. And I actually live in mid-America, so I live in Arkansas. So if you look at it, more and more people are not only moving to the Western states, those coastal states, more and more moving towards mid-America. And it's very, very different, life in mid-America, right, from those coastal states. We also have to consider that we are in what we call active migration. So people seek healthcare and go to school. They're still based in the US API, but they go back and forth. So we also look at that. We run a diabetes program that is a 1-year program, but they started out in the US API, but they ended up in month 4 or 5 in the US and they go back, and then the other way around also. So we have to look at this dynamic of active migration when we're looking at research. So what does that, how do I operationalize our Tofa Manino, that clarity on who we are, what we do, and people, Pacifica people. So I always talk about, this is one of my favorite study, looking at diabetes. We all know the prevalence of diabetes, 35% in the USAPI versus 8% in the US is dated, but that's the data that we have. And it's around amputation, so amputation 18.7 per 1,000 for diabetes patients, but that is very high, compared to the US of 5.5. So we were looking at this of like, go to the doctor, get cleaned up and all of that. So there were barriers, so we did it in Chuuk, in many of Pacific Islands, the road, and not only in Chuuk, but in other Pacific areas, and improper footwear. And then we also look at secondary prevention, like knowledge, practice, and then resources. But our intervention, at that time and even up to now, what we're looking at is increasing not just foot care knowledge, right? And understanding how to take care of it, but what is our indigenous view of caring for one's body, right? And then also, what is our view of caring for each other? So the intervention was mostly not just educating people on how to take care of their food, when something happens, but also collectivistic culture, how, your family member can take care of you. But I think what was critical at that point, and even up to now, is looking at our traditional medicine and how we use traditional medicine in wound care and all of that. We also look at our attitude, towards food care, right? In a lot of culture, taking care of feet, it's like the least, job, right? So looking at that, not just, just band-aid it up and do that. So what the intervention actually look at the medical model, we're looking at cultural model, we look at spiritual model, right? The importance of your feet in our spiritual practices. But then towards the end, a lot of the folks that were in this study and this program actually felt that it's much more than that, right? So, there were a lot of conversation around spiritual health at this point. Very interesting, right? Talk about our food, but we talk more about spiritual health. Long story short, towards the end, there was increased practice at food care, nail clipping, filing, and all that, food check, wound care. But then we went back and then it's an older study and look at change, right? So if you look at debridement, disarticulation, amputation, they all decreased like 42%, 67, and 56%. And, I feel like the reason for this is because we look at everything, not just one part of your, just the physical part. And I feel that's very typical. It's just an example of incorporating our culture and our spiritual beliefs into healthcare and research. You have to look at everything. And I feel like it's something where it's the path that we need to take to get there. So So we also do the same thing around breast cancer screening. So if you look at it, so this is also another step here in Hawaii. So Community Health Center, they did a chart review. 26% of female Micronesian patients over the age of 40 have ever had a mammogram. And in the state of Hawaii, that's very low, right? 26%, because we have a high rate at that point of 78.7%. So what we did was we did a Micronesian United Breast Cancer Project. As a cancer survivor, this is something also that's close to me. So we reach at 202 women over the age of 40, 18% never had mammogram. 202 women is a significant number given the number of Micronesian women living in Hawaii at that time. So we did a Micronesian United Breast Cancer intervention. We were able to screen 90% of those women. And actually that increased the state of Hawaii, mammogram or breast cancer screening during that time. So it's interesting. And so what did we do? So we reached out to churches. We actually have a spiritual talk around taking care of one's body. We look at, language. We translated curriculum and training materials into 7 Micronesian languages. We also, utilize community health worker and then also church leaders. And I think during COVID-19 was another time where we leaned a lot more into church leaders and then provide them the tools to educate their people in their churches. So in that way, we're now looking at all that tofa. So I just explained what is tofa manino, like understanding one's culture, one's positionality, and then looking at health and then health research. Now we're getting into tofa loloto. Again, tofa loloto is dive deep into the issue that we have in hand. So tofa loloto, there's a lot of talk about drivers or determinants of health. But in our conversation, in our Talano with communities, we call it social health we're looking at social determinants of health, but we also need to think about that narrative because health also determines other things, right? So it's not like a one-way pathway. It goes around. A lot of people, they lose their job because of health, right? So therefore, they go back into the loop. So it's highly complicated. And then as community, we do have community discussions around social determinants of health and how we do see things. So there is difference of determinants of health in the USAPI, Hawaii, and then also the continental US. If you look at it, we also look at culture as a determinant classism, insider versus outsider, lack of support due to migration. If you look at those kind of things as determinants, it make it a lot more complex, but also make it easier to understand and address. So as researcher, sometimes we face something, we're like, well, that's culture. Culture is complex. When you look at things that are complex, we try to reduce it. We're reducing the complexity, but at the same time, we're not addressing solution, because solution also need to be complex. So if you look at this very busy slide, this is something that we are actually, Dr. Kolokula and I, and then Dr. Daniels, we're looking at this as part of our research project, is looking at all the determinants of health for Pacifica people, how to measure it, and then also address it. And in the continental US, we do have our UMU crew, a lot of community members that meet monthly to discuss issues like this. There's continue to be a need for a space like that. So for me, it's something where researcher, you don't have to do it all. I'm speaking to my researcher, my colleagues as research, we don't have to do it all, determine or address every determinants of health, but it's something that we need to consider, because your intervention is not going to work in community if you don't look at those things. We also look at enabling services. So I also a consultant or member of the APCHO, the Association of Asian Pacific Community Health Organization, with the Center of Primary Care Excellence. If you look at it, the utilization of community health worker and eligibility assistance worker, community health workers and interpretation staff is very high in NHPI serving community health center. And the reason why they continue to hire and train, because there is a great need for it. And I feel like there's a lot of research that needs to be done about the role of community health worker. That's another project that we're starting to do it, because I think we continue to look at just the health outcome, right? Like diabetes and cancer and all of that, but we fail to look or consider the process, like all the things that need to get in there in order for make that happen. Researcher, we tend to focus on one thing and what you're researching, but not the process. So that is also the one reason where there's myself and many other community researcher, because that's a space where we can have the opportunity to look at it all. So, and so an example of that is our National Diabetes Prevention Program, right? So we have to adapt it for and to tailor for Native Hawaiian Pacific Islanders. So we also have to follow the curriculum, right? It was a federal grant. We have to use curriculum that has been established. So, but we need to tailor to meet Pacifica folks. So this process was done through collective participation and required trust. So trust is important. I think maybe I won't have time to talk about the role of trust in the work that we do, but join our UMU talk. We do a lot of those things, but the process was done through that way. We also prioritize language, cultural worldview. So it's not just translate, right? People think like if you would just translate from English to Koshayan or to Pohnpei, everything will be solved. No, there's a worldview also needs to be translated into that. We have to also translate our context, right? Context in the NHPI Hawaii and the content is very, very different. But how do we fit all of that into a curriculum? It can be done. So be part of a community that are doing that right now. A lot of our communities are in all three regions, USAPI, Hawaii, and the continent. And we're also opening up that space for non-Pacific Islander to come in and just sit in and listen to the UMU crew, have those conversations. I think there's need to be spaces like that for researcher to come in and observe and experience the way that we do things. The other things that we did, we also incorporate social determinants of health interventions and other health needs. So that can be something like a tarp. I remember our Maui group, all they did was they just put a tarp by the end of a very busy road, a blue tarp, and the classes was in there, right? Because they made it closer to home. People can walk there, they feel safe there and all of that. So there, solve transportation issues, right? Not everything needs to be done in a clinic or in a centralized area outside of where people live. We're taking our programs and our resources closer to community. And then also investing in healthcare system partnership, clinician engagement. This is something where we have to look at this church to clinic, community clinic, street to clinic, anything like that, so, but we've been doing that from the beginning of time. So I remember I went into like a research discussion, look like we need to look at, there's linkages and things like that. And somebody that been doing community work, we've been doing that forever. So how can then we do research that is started from community and then bring it forward to academia and then into the Western way of searching knowledge and wisdom? So did all of that work, so at the end of the day, it did. So the grants, they target 1,000 participants. So that's 1,000 participants with pre-diabetes, right, a year. So our average actually was 1,300. We have a waiting list right now. We always have a waiting list from year one, so we ended up with 1,000 participants per year, more than 1,000, and that's only with 8 sites, and then in year 2, and then up to 9 sites in year 3. And we're supposed to cover all of the USAPI and a lot of the folks in Hawaii, but we have to stop, in year 2 because of our high enrollment rate, right? Retention. 44, so from year 1 to year 4, we started out with 44%, in year 1, and then up to like 80% in the latter years. But, everybody's like, well, 44%, right? That's still double the national average around retention. So we're able to recruit. We're also able to make them stay in this 1-year-long class, right? So that's very, very high. And then you look at the third thing was weight loss, right? So the average weight loss, so for year 1 to 4, it was 5.15%, right? And that is high compared to our other programs in the continental US with other groups. So 5.15 for us, but 4.6 in our what we call the 1705 grantee. So that's very high. We reached that also. So if you look at it, that's how we measure success in the Pacific by Durham Pacifica ways. But not only that, if you look at our delivery site certification, right? So it's a long process. You have to certify the sites because our IANA price is reimbursement, right? So if you are a researcher here, there's a lot of research that we need to get to, that we need in Pacifica communities to make this happen. So if you look at it, in order for you to be a site, you have to be certified. So that is something where we need to look at also. And then for us, it's 1 to 2 years, and other is 3 to 4 years. Look at weight loss. The funny thing about this chart right here, at the end, we're at 6.50, but at one point was 3.9. The reason was not weight loss. Everybody was losing weight. The thing that was matter is because in order for us to count their weight, they have to look at their physical activity. And a lot of them were not, documenting. So we actually were able to solve that. So that was Tofam Loto. But look at Tofam Mamao. We got to look at into the future, which is perfect. This is where we are at right now. We're looking at our health issues. We got to look at maternal child health. So we do have a Pacific Health Gathering. One is coming up in Alaska the last week of October. It's a larger gathering of Pacifica people, 300 to 400. We have to limit due to space. But the last gathering, we're prioritizing maternal child health, youth mental health, wellness, chronic disease prevention, and elder care. I also put out some of the process issue. There's a disconnect between research, community intervention. We need community evidence-based intervention and evidence-based programming. We're lacking researcher to do that kind of research for our community. There's also looking at community engagement in research. Engagement is passive. We need to look at community-led and involvement in a different way. And then also there's research, and investment in community is also lacking. Looking at, our processes, we need real culture-based intervention. We also need to build up workforce, not just community health workers, there's community educators, our clinician, lifestyle coaches. We also need to expand. As I mentioned earlier, all of these programs that's been successful, we need to expand it. Why don't we use the same process, similar? Look at cancer prevention, maternal child health, mental health. We need to increase documentation on social determinants of health. We're not best at documenting anything Pacific Islander people, but during our diabetes studies and during our diabetes program, we actually master documentation. So there's a process that needs to be out there and to be taught. We also need to look at the sustainability of our wellness program. So final point for our community researcher, one of the best way to be a good researcher is involved in public health programs, because a lot of evaluators in public health programs, that's how you get your innovative idea for future research, because you're in community, you listening to our conversation. That is I feel like that's one of the best way to find innovation from community. And then that's it. So earlier on, I talk about tofa, which is wisdom, and then all of the tofa that I talk about. But there's one more tofa that I need to look at. So when we say farewell or goodbye to one another in the Samoan language, we say tofa soifua. Giving blessing of tofa, wisdom, and soifua is health. Isn't it interesting? People think that we don't value our health, but we do. The way that we bless each other before we depart, we say tofa soifua. And with that, I wish you all blessings of tofa soifua, good health. Thank you.
Thank you so much, Nia, for that wonderful message and that wonderful start for our keynote. I do recognize that there are a number of questions that came on through our Q&A box, and I do wish to respect the time that's been allotted for our other community keynote speakers. So with that in mind, I hope for those who've asked that we will bring this up in the breakouts, because that will probably be the most appropriate and allow for the most time. So for our next, we have Puni. Puni, I did introduce you earlier, so by all means, please proceed.
Aloha kakayaka, everyone. Good morning from Hawaii. And aloha to our guests. Mahalo nui for the opportunity to present this morning from our community in Papakolea. Our presentation this morning is called Ke Alaula, a new day, light for a new day. Okay, you can click that. Okay, next slide. This is our community. So Papakolea, our community, is a 177-acre Hawaiian homestead community located in the city of Honolulu. We're comprised of 3 land tracts, Kalawahine, Kewalo, and Papakolea. And then we are known as the Papakolea region. On May 16, 1934, the United States Congress designated this region as Hawaiian homelands under the Hawaiian Homes Commission Act of 1920. We in Papakolea have a very strong reverence for our kupuna, our elders, as they are very deeply woven into the cultural fabric of our community and the work that we aspire to do on behalf of their families. Our population totals 2,077 Native Hawaiians, of which 30% are kupuna over the age of 55 and 27% are under the age of 18. The number of homes in Papakolea total 427. So in order to, I'm going to share our journey in 10 minutes. I'm going to try my best. We're going to make this real quick. So Papakolea, you know, for us, you have to have a vision. You just can't. I am a community-based nonprofit organization. And for community, we need to have our grounding. In 1997, the kupuna Papakolea and the families here drafted and finalized this vision statement for our future. Our home is Papakolea, a community where the spirit of lokahi and aloha inspires self-reliance and participation to share knowledge of our culture, respect of family, or ohana, where residents assume a responsibility to create a community with strong identity, spirit, and pride. And our participation nurtures our growth in education, economic well-being, and improved health conditions for generations to come. Next slide. Okay, next slide. So here is our organization. I'd like to introduce everyone to Kula no Nā Po'e Hawaii o Papakolea Kewalo Kalawahine, also known as Kula. We are a Native Hawaiian beneficiary serving organization that promotes cultural, educational, environmental, and health equity for everyone. We've been doing this work for 30 years, in Papakolea on behalf of our community. And we are very proud and honored to represent Papakolea this morning. Mahalo nui. Okay, next slide. So here's life before CBPR. So prior to the mid-70s, prior to the 1970s, research canvassers and people as the most highly concentrated community in Honolulu with Native Hawaiians. This community was surveyed continually. There's no information, no reports or findings were ever shared with the Papakolea community during that period of time. Residents in the 70s were asked to halt, stop participation, stop giving people access to your home. It remained closed for 30 years. Click. Okay, next. Next slide. So here are the key to Papakolea's efforts in research. Trust. The most important key in research is gaining the trust of your community, kupuna, and families. We had to go to kupuna to ask for their permission to open the doors and allow us to come in to conduct CBPR. The conditions, this is what we had to keep our promises. We had to own the data. The survey instruments needed to be housed in community. We were required and asked that we had to produce community reports after each survey, identify what's the problems and how you're going to address it. And all publications on Papakolea data must have Papakolea people in authorship. That was the requirement. And from there, we started to provide and conduct or create the networks and partnership. Okay, click. This is a mo'okuau hau. So for Kula, in our culture, you introduce yourself by your lineage or your family line. In the world of CBPR, here is our lineage. All the projects above the line are projects, CBPR projects that Kula has done with our academic research partners from 2005 to today. And they include a wide gamut of different projects, and we can get into that later during our breakout sessions. All the projects on the bottom are CBPR projects that were done by Kula. Kula initiated, planned, drove it, and today Kula has a Aim Ahead project under NIH with the University of Texas, with NIA as our partner, and Kamalu Moana Nui, and Kamalu Papakolea. This project will enable us to use AI/ML to better equip community health workers to be on the ground, helping our community and kupuna. Next. We can click. Everyone knows this theoretical framework. I'm sure everyone has worked with it. Thank you to Dr. Nina Wallerstein and Bonnie Duran for coming to Hawaii that year. We always remember the time we spent with them, understanding and learning this theoretical framework. We took this framework, and over the years, we have updated it. Okay, next slide. So Kula's theoretical framework is here. So we took CBPR and translated it into our own traditional Hawaiian values. We incorporated all the CBPR values, and you know, we have to explain to community. We have to make it relevant and easy to understand. We took all those principles and we laid it out in our traditional Hawaiian values of aloha, malama, na'uau, pono, nalu, and kokua. Next slide. Data gathering. Okay, so in the last 20 years, Kula has conducted and gathered data from our community. These are some of the scans and surveys that we've done starting in 2003 with our Kupuna Service Planning Survey, where 233 Kupuna participated. And over time, and with the gaining of trust and keeping our promises, we were able and are able to continue to garner support and participation in gathering data. At the end of all of this, the very last that we really are proud of is the Hawaiian Homestead Health Survey. We have conducted this survey throughout 11 Hawaiian homestead communities in Hawaii. And this is within 2015 to 2023. We produced 19 community reports. I'm very happy to say that we've expanded beyond Papakolea. Next. Okay, next slide. We've adapted, we worked with Dr. Lana Kaupua and Dr. Suresh Tamang, and we created with them a cultural safety model. This is the Hilina'i model. Hilina'i means trust. So Kula utilizes this framework to make sure that the community of Papakolea can be engaged on our terms to advance self-sufficiency, self-determination of Native Hawaiians, and really to behave, to act in the preservation of our values, our traditions, and our Native Hawaiian culture. Okay, next. Next slide. So here is Hilina'i. So we've taken Hilina'i and created an acrostic, and this is what we use when we meet with our academic partners in research. And it's a process for looking at, again, keeping our community safe. So honoring our community's history, we go through this with every research person that comes through, honoring our history, introspect, looking at our personal and organizational balances, you know, how that how that may influence the research, learn about who we are, what we know, how we, you know, be open to learning from us. And the same comes from us to the practitioners or to the researchers. Involve yourself in the community activities, get to know us, hang out, be part of the projects. You know, that's really going to set you up to succeed. Be part of community. Nurture meaningful community participation in research. Act to enhance research capacity, right? So throughout the time of working with the Department of Native Hawaiian Health and all our academic partners, that has been key to work with us in building our community capacity and truly partnering and mentoring during CBPR projects. And then insurrect relationships of unequal power. We've been at this for quite a while, and we've become quite bold in needing to speak to some things that are not working out. And I think community needs to be empowered to do that. You do need to be empowered to do that. Okay, click. Next. These are the projects that we did. So it's all about addressing, you know, when we look at CBPR, it's really about identifying the social determinants of health that we all talk about. And when you get when we receive all that data, right, all of that data I shared with you, what are we doing? So again, keeping the promise. So within the health programs, all of this data, we were able to do a whole, a plethora of CBPR projects, Pili Ohana, Partners in Care and such. Education, same thing. Workforce development, all came out of the data. And then in environment, what do we did to help Hawaiian homestead people live safely in place? It's just Kupuna. Okay, click. And here are the lessons learned. CBR principles are best implemented when shared values can be achieved. Scientific discovery with community and researchers. Useful training gives community information and platforms to benefit our communities. Cultural differences in communication and expectations must be considered appropriately during implementation. That is key. And then projects should never be entered into with communities without training on financial processes and the possible challenges that are to be expected. Yeah, these are some of the lessons that we've learned and opportunities moving forward. Click. Okay, next. This is pursuing the vision. So these are future endeavors. No kako, nakako, Kula has taken this mantra for us, by us as a result of CBPR. We're creating a Papakolea data warehouse right now that's in the works. We've learned that we need to create our own curriculum development. We need to stop adapting existing curriculum and start developing our own. And we will be doing that and creating our own community health worker, a Native Hawaiian community health worker curriculum. And last but not least, we in 2023, we have requested 7.25 acres of land on Puawaina in Papakolea to develop the Hawaiian Homestead Health Innovation Center on Kupuna Aging and the Native Hawaiian Research Institute. Purpose of this is to increase capacity of CBPR in Papakolea and partnering Hawaiian homestead communities across the state and advance the health and well-being of Kupuna to enable them to age safely in place. This is our moving forward. Click. Okay, I'm done. On behalf of all of us in Papakolea and our Kula no Napo'e Hawaii staff, I'd like to thank you for the time. I'm sure I'll get to see everyone in the breakout rooms. Thank you so much for this opportunity. Mahalo nui, ahui ho.
Thank you so much, Puni, for that presentation. And our final keynote, our community keynote speaker will be Paige. Paige, you have the floor.
Thank you. I am actually going to share my slides. All right. Well, Hafaday Todos Hamzu. Thank you so much to NIMHD and Dr. Keave and Dr. Michael for allowing me to be here. I'm not quite sure how I'm going to follow such wonderful presentations. I'm just really honored to be here. Today, I'm going to be talking about Ihananauta, our journey, and the stories that we carry.
Paige, I just still see a loading screen on the presentation. Is that what you see?
Oh, no. Let me try this. Let's try this. Okay. Can you see my slides?
Is it just me? Keave, can you see her slides, or is it just me?
No, it says
It's still
loading.
loading.
Yeah.
Do we have it at our end? Can we run it?
I have updated slides.
You may want to put them in presentation mode before you share your screen, and you can use Command Tab to move between the apps if you're on a single screen.
Let's try that. How about this?
I just see something about starting screen sharing, but that's about it. Oh, I see a blank white. Okay, I do see it, and you start, yeah, start that slideshows. I don't know if it'll still. I'm still seeing a loading screen.
Oh, no.
Oh,
There it
no,
is.
I see it.
Wonderful. We got here. Okay. So again, today, briefly, I have a few minutes, and so I decided to take that time to tell you a story about my family. And this story starts with this photo. This is a photo of my great-grandmother, Maria Nauta Castro. At 15 years old, in 1935, in the former village of Sumai on Guam. My great-grandmother is really important to me in that she raised my father, who is here in the audience today. So much has changed for my family since this photo was taken. My great-grandmother survived war. She witnessed a lot of loss. She gave birth during World War II to my grandmother. And where this photo is now taken is now Guam Naval Base. Because of many different circumstances, my family moved from Guam. Here's a picture of my father in Talofofo, and moved from Guam in 1969, where he lived with his great-grandmother and family. I still have some family on Guam, but for the most part, most of my family lives in Washington, California, and some in Nevada and Texas. Like so many Pacific Islander, Pacifica families, my family has faced many health challenges, including cancer, heart disease, diabetes, asthma, and others. Because of this, I grew up knowing that I wanted to go into a career towards medicine. It really planted a seed. I was privileged to go to the University of Washington, where in hopes to pursue medicine, I obtained degrees in biology and international studies. I had some really wonderful experiences while at the University of Washington and quickly pivoted towards public health, which led me to applying for a research assistant job at a national nonprofit organization called Community Campus Partnerships for Health. The study that I joined was a really impactful one. As a research assistant, we were looking at the contributions of community-led research review processes, both informal research review boards within community-based organizations, as well as community, federally recognized community-based IRBs. I had the privilege of working with 2 Pacifica organizations, including a Chamorro one in that time, and it really had an impact in how I navigate professionally as a Pacifica woman in diaspora, looking to see how I can contribute to the health and well-being of my family. 10 years later, a gap year job has turned into a professional home. I have been a part of multiple community engagement research projects funded by various different funding agencies, both federal and private. I was promoted to Deputy Director of CCPH in 2022. I am a part of that NIH SEAL interest group that Dr. Eliseo mentioned earlier today. I also became a mother. I was promoted to Fiesta Auntie, meaning I'm in the kitchen with my grandma now. I began learning my language and connecting to other community groups around me that share the same Indigenous and Pacifica values, including being a part of the Pacifica Village Council, which is facilitated by the Pacific Islander Community Association of Washington, where we advocate and track policy that is happening in our state that impacts our community members. I share all of this to give a little glimpse, a sliver into what it's like being a Pacifica person in diaspora and trying to understand who you are. There are a lot of external perceptions about our people. This is a map, the first European documented map where the island of Thieves, Islas de las Ladrones, was the name given to the Mariana Islands to my people. And throughout my time at CCPH and just with the people in the communities that I've shared space with and that I've been raised by, I really began this journey of decolonizing and understanding the impact that colonization has had on our people, including internalized stigmatizing narratives about who we are and what we're able to do. And as I've grown, I've began to see really the full impact that colonization has had on the health and survival of my people and our culture. For example, Dr. Diaz here has really given the unique context that Pacifica has politically, understanding what impact territorial status has as a social determinant of health for Indigenous persons on Guam. I share this and these stories because it really has been quite a journey. So much has changed for my family and for families like mine in just a few short generations. And I'm so grateful again to have shared space with so many mentors and elders, both in community and in my family, and some here today, where these key messages are really important that we carry as either community-based researchers, as leaders, as funders, as decision makers, policymakers, that these actions and considerations within your research have a real impact on who we are as Pacifica people. And so I know we are going to be talking about a couple of these things throughout the next 2 days, but I just kind of, to give it a community perspective, that when we're talking about data disaggregation, we're talking about being seen, we're talking about being heard and honored. It's really important that we all hold both the stories that we carry and the ones that are shared with us with respect. And that's why I implore community meaningful reporting be a part of every single project that you do. We also have so much that we can share. Nia did a wonderful job just explaining all the different ways that we see the world through and that are evident in the languages that we have, and just honoring that expansion. And I'm really excited for some sessions coming up where we will be talking about these culturally relevant measures. Another thing is around how research must be a tool for communities to rise, that community participation is not it, it's really about research towards action. And I think it's critical that research that is supporting our communities, whether that's in the partnership or in the research itself, be geared towards action, including advocacy, policy, and structural change. And lastly, reciprocity and nafamaulik. This is a value that is deeply entrenched in many of our cultures. And unlike the European explorers who deemed us the island of thieves, we're actually just asking for reciprocity. And this certainly includes NIH sustainable financial resources for our community partners that are close to the communities that are deeply impacted. And I just really am hopeful that through all of the work that's been done around community engagement and funding it and pivoting beyond COVID, that this is something that can continue to be possible. Now I'm saying this out to you all just as much to myself as a young mom and professional in this space, in diaspora, trying to understand myself and learn how to better help my community. The stories that we have are not just one of despair, of sickness, and of sadness. We really have a lot of abundance, and we contain a millennia of experience in changing tides, respectful cultivation, and boundless beauty. The name of Guam, or Guahan in Chamorro, means we have, and our ancestors and our elders have always viewed and honored the abundance that is here in this world. And I am grateful for those that have shown me to see that in myself and in my communities. Thank you so much for hearing my story and for taking the time and care that you all take with our communities. I'm here because of the strength and fortitude of my elders and my ancestors. And I am really excited for all that we discuss over the next few days. And I just thank you again for honoring this space. This is a real spiritual, emotional space to be in, and I'm just really grateful and look forward to what we can all do together. As many know, the ocean does not divide us, it really connects us. And so please reach out. I admire so many of you here today, and I'm just really grateful to have been included in this service. Thank you.
Thank you so much, Paige, for that wonderful message and that really beautiful video you just shared at the end. So, and also I want to again thank Puni and Vernia for starting us off on this and for this wonderful keynote session. And recognition of the time and the importance of trying to move things through, I will now have us transition over to our first session, which is titled Determinants of Native Hawaiian Pacific Islander Health. And I will have Dr. Angela Fernandez lead this charge. Angela?
Also, hello, everyone. I'm Angela Fernandez. I'm a member of the Menominee Nation of Wisconsin, and I'm a program officer and proud to be on this planning committee. I also want to say a mahalo, wawanan, thank you to our keynote speakers for their powerful stories, sharing their work, teaching us, to Dr. Keawe Kaholokula for the opening melee, to Dr. Keawe and Dr. Mike Spencer for their co-chair leadership and guiding us and opening in a good way, and to NIMHD leadership and my colleagues for organizing this important workshop. So without further ado, I want to say how honored and humbled I am to introduce these distinguished speakers and discussants for the first session, Determinants of Native Hawaiian and Pacific Islander Health. So I will start with Dr. Noreen Mokuau. Dr. Noreen Mokuau is a multiple principal investigator of OLA Hawaii and NMHD RCMI Specialized Center located at the University of Hawaii at Manoa, John A. Burns School of Medicine. She's a professor emerita and the former dean of the Thompson School of Social Work and Public Health. As a Native Hawaiian educator with nearly 40 years of service, Dr. Mokuau's scholarship and teaching are grounded in social justice and health with attention to the diverse populations and unique attributes of Hawaii and the Pacific Asia region. After Dr. Mokuau, we will hear from Dr. Reynald Samoa, who is currently an associate professor at the City of Hope. Dr. Samoa serves on the President's Advisory Commission on Asian American, Native Hawaiians, and Pacific Islanders, and is the co-chair of the Data Disaggregation Subcommittee. In 2022, Dr. Samoa received the Robert Wood Johnson Foundation Award for Health Equity. Dr. Samoa is currently an investigator on a study from UC Riverside aimed at conducting a needs assessment of Indigenous, Queer, Trans-Pacific Islanders, QTPI, residing in California and Washington. And our session one speakers will conclude with Dr. Ta'usili Tofayano, who is the executive director for the American Samoa Community Cancer Coalition and principal investigator for multiple NIH-funded research studies. He began his career in public health, managing various programs funded by the CDC. And in 2015, he transitioned to research at the ASCCC, was awarded by the National Institute on Minority Health and Health Disparities to build research capacity and assess health literacy in American Samoa. So again, I want to say wawan and mahalo. Thank you again to our speakers, and Dr. Mokuau, the floor is yours.
Aloha kako. Thank you, Director Perez Stabler, co-chairs Kaholokula and Spencer, Workshop Planning Committee, for acknowledging Native Hawaiians and Pacific Islanders and facilitating a workshop intended to improve our health and well-being. It is with great pleasure that I join all of the participants of this workshop, and in particular my colleagues, in the session on the determinants of health, in order that we share information that will support our dreams of better health for all our people. Next. Although we are a relatively small population compared to the other groups in the United States, we are diverse and growing. In the last 10 years, nearly all 31 groups grew significantly. Next. There are many ways we can find the determinants of health, but I think foremost is to view it as complex and intersecting conditions or domains that influence health outcomes. These are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of life. Determinants of health also include the specific domains of influence: biological, behavioral, physical built environment, sociocultural environment, and the healthcare system. Next. These elements of a definition are reflected in the different conceptual frameworks on determinants of health. These are three which many of you may be familiar with: the NIMHD research framework, Healthy People 2030, and a relatively newer framework, Mauiola, courtesy of Dr. Kaholokula. Next. Perhaps the framework with the most meaning for this particular workshop is the Determinants of Native Hawaiian Pacific Islander Health Framework proposed by the NIGMS Center, PICO, Center for Pacific Innovations, Knowledge and Opportunities. This framework includes both a life perspective and intergenerational perspectives. It moves in different spheres, from the intrapersonal to the personal, to the interpersonal, to the community and the geopolitical. The factors or determinants of health indicated in the red circles are those in which I hope to provide specific examples in the following slides. Next. One other way to view our ideas and organization of our ideas on determinants of health is to look at it with movement. At the downstream level, micro level determinants include those with individual drivers, the personal and intrapersonal factors of genetics, gender, healthcare utilization, and so forth. So the way we would advance health at this level would be through high quality clinical care. I believe that most of our work in health has been directed at downstream or micro level determinants. If we move midstream to meso level determinants, we are looking at advancing health by improving living conditions. So the social drivers within our community may include examples like food sovereignty. As you move higher to upstream or macro level determinants, our effort would be to advance health through the changing of laws and policies that would encompass entire society. So these structural drivers are geopolitical, and an example of that may be racism and discrimination. Desmond Tutu, Nobel Peace Prize laureate and human rights and justice advocate, said, "There comes a point when we need to just stop pulling people out of the downstream river, and we need to go upstream and understand why they're falling in." Perhaps I can provide some examples of determinants at these various levels, primarily based on the work of an extraordinary team of research investigators of Ola Hawaii, an NIMHD-funded RCMI center. Next. So if we look at downstream micro-level determinants first, we might look at, say, health services, access to and utilization of health services. We would know that with lack of access for our people to services, there would be delays in receiving appropriate care, hospitalizations that could be prevented, and just basic unmet health needs. Next. So two researchers in Ola Hawaii, Drs. Morgan and Yes, have undertaken a research project on looking at improving health for Native Hawaiians and Pacific Islanders in the area of diabetes. They postulate that there's 2.5 times more likelihood of Native Hawaiians and Pacific Islanders dying from diabetes than non-Hispanic whites. So their effort at a downstream driver is to improve access to healthcare through a project that integrates culturally trained, community-based navigators in a primary healthcare setting, the Queens Medical Center, which is the largest public nonprofit hospital in Hawaii. Eventually, their upstream driver would be to engage in cost analysis, which would sustain the program. Next. If we wanted to move to meso-level determinants or midstream, we would be concerned about social and physical conditions in communities that impact health. We know if we don't do this for our population, possible results would be houselessness, food deserts, and just unmet health needs. Two examples follow. Next. One example is on food sovereignty. Dr. Chung Do and Holas Tismosa of Ola Hawaii have a project examining backyard aquaponics to reduce cardiometabolic risk among Native Hawaiians. In Hawaii, they recognize that 35% of Hawaiians experience food insecurity compared to the state average of 13%. So their midstream driver is to reduce food insecurity by developing family-based backyard aquaponics in high-density Hawaiian communities. Their upstream driver would be to eventually sustain this program, not only on Oahu, but statewide. Another example, next, relates to income and housing. Researchers Drs. Devandra and Park are currently looking at long-haul COVID in Hawaii. They recognize that Pacific Islanders have disproportionately high rates of COVID infections, hospitalizations, and deaths. So their downstream driver is to improve knowledge of and access to vaccination. They are wisely concerned about upstream drivers and looking at the understanding of the determinants such as income and housing with vaccination levels and immune dysfunction in COVID-19 survivors. Next. At the macro level, upstream determinants are those that are structural drivers that can impact health. An examination would be factors of discrimination and oppression, limitations of laws and policies that do not account for our people's needs and services, society's failure to include cultural norms and practices, and society's resistance in acknowledging historical trauma as a root cause of health disparities. Two examples follow. Next. Dr. Lorinda Riley, also of Ola, Hawaii, has undergone research to examine historical trauma among justice-involved and at-risk youth among the Native Hawaiian population. She is psychometrically testing one measure to develop evidence-based methods to establish critical data that will inform policymakers about the prevalence of historical trauma in Native Hawaiians and to compel the need for healing programs. Next. Another example relates to climate change in Micronesia. Pacific Islanders in small, low elevation islands are at risk always for sea level rise, flooding, and other adverse weather conditions. In 2007, there was an acute onset sea level rise in Micronesia, causing extensive damage, subsequent food loss, and the destruction of healthcare resources. In 2024, we saw large waves destroy a military base. The upstream driver for this is the development of international policies and standards to create climate change globally and the creation of effective health protection interventions for high-risk islands in Micronesia. Next. Next slide. So despite all these health and social disparities, Native Hawaiian Pacific Islander roots are diverse, intertwined, strong, and growing. The resiliency among our people and the growth is in the requirement that there's a balance of cultural worldviews and values and practices in Western-oriented healthcare services. Next. In conclusion, if we had to make recommendations, it would be highlighting the need to continue to push upstream, to look at the root causes of health disparities and to examine this in the determinants of health, and to always be mindful of the intersections of social justice and health. The Ola Hawaii team in a survey last month actually came up with their own suggestions on how to examine and resolve determinants of health and health disparities for our population. In summary, they say, listen to the stories of the people, invest in developing the pipeline of research collaborators and community partners, include Native Hawaiians and Pacific Islanders as NPI or co-investigators, fund research that's culturally anchored and community-based, prioritize research that's transdisciplinary in order to act upon the multiple domains and levels of determinants, and to develop a comprehensive informatics systems as a foundation for research on the determinants of health. Mahalo, you all.
Mahalo, Machuawen and Dr. Mokuau. Now we'll pass the baton on to Dr. Samoa.
Okay, I think I'm driving. I was up for a second.
Sorry, when you said I think I'm driving, I thought you meant you wanted control of the slide, so I stopped sharing. But I can pull it back up.
Oh yeah, I thought I would be able to advance it from here. No, if not, that's okay. You can advance now.
Oh, I see what you mean. Sure. Let me put it back up and give you control.
Sure. Okay. Do I just click it?
Oh, yeah, you should have control now.
Mark, you may need to put more of a present because it has the presenter display as opposed to the presentation. You probably need to swap display. There.
Oh, there it is. Okay. So my discussion is, or my presentation is on the indigenization. And so I thought I'd center a lot of the people that contribute to sort of my view of indigenizing data collection, social determinants of health. So this was the convening of the group that I'm going to speak about in Montana. And so, once again, my name is Reno Samoa. Let's see. So I'm going to look at the social determinants of health through a DEI or diversity, equity, inclusion, justice, belonging lens. And so this kind of ducktails into what Noreen was talking about, in that the diversity that Native Hawaiian and Pacific Islanders bring, as you see, as you've heard many times before, you know, we come from a very large conglomerate of ethnicities and histories. And a lot of that had to do with the history of colonization, which is well summarized in our keynotes. And kind of what makes us different from other groups in the United States is that our indigenous lands are now part of the United States. And yet, even with that condition, we're statistically invisible, being that we're a small population held to a lot of statistical regulations. And so what does that mean for our equity? Well, it hasn't produced, there's been a lot of inequities that's come from it. You've heard already the higher risk of diabetes in NHPI populations, also the higher rate of mortality. There's also higher rates of heart disease, and as well as certain cancers, which are, you know, the three main sort of leading causes of death in the United States. What does that leave us with inclusion? Well, we still have a lack of access to a lot of key areas in regards to sort of our well-being in the United States. We have lower rates of insurance, and we also have lower rates of academic achievement. And what we see in the future is that this number is probably going to get worse as the number of NHPI students entering college seem to be decreasing. And so from a justice standpoint, there's a lot of injustice still to be had. NHPI have the highest rate of homelessness out of all racial and ethnic groups. And despite the 1997 revised OMB 15 standards, which mandate the collection, analysis, and reporting of disaggregated NHPI data, the majority of federal agencies still, you know, do not meet this mandate. And so, what does this mean for our belonging, right? So because of this, I'd like to use a case example to sort of demonstrate belonging from an indigenous sort of view. Invisible doesn't equal belong, right? And with the general U.S. population, if you can look at it as some type of animal, our analogy with that Native Hawaiian and Pacific Islander data is almost like the flea on that animal. And then if you look at smaller, more marginalized communities like the indigenous, queer, and trans Pacific Islander population, they're the single cell organism on that tick, you know. And so we're talking multi-levels of deep disenfranchisement. And so the group that we had mentioned before had centered trying to get more information regarding the needs assessment of this group, which is oftentimes sort of not reported. In fact, the only sort of data reports that have come from Indigenous Queer and Trans Pacific Islanders just started a year ago. They were just published in 2022. And so this survey just concluded not too long ago with the help of Dr. Andy Subika from the UC Riverside. And as you can see, there was a fair number of respondents with 255, with a very good spattering of representation in regards to the other demographics. So what was some of the sort of major things that was found by the study? Well, one of the most glaring things that was reported was the percent reporting poor fair health. So to give you sort of an idea, of the context we're dealing with, ethnic populations, you can see here that according to the KAFF analysis, there's a wide range when you look at sort of ethnic and racial groups and the reporting of poor and fair health, with Asians reporting the least percentage at 9%, and American Indian and Alaska Natives having the highest at 25%, with everyone else in between, but most notably Native Hawaiian Pacific Islanders at 12%. And so when we looked at sort of what was reported for the general LGBT community, they reported 25%, which was very close, or basically equal to American Indian and Alaska Natives. But Queer and Trans Pacific Islanders reported a whopping 35%. So a very clear disparity when it comes to health descriptions. And so why is that? Well, if you look at sort of the report, the percent reporting discrimination, you know, as was said before with Noreen, that the social determinants of health have a huge inplay on health. And you can see the high levels of discrimination that Indigenous, Queer, and Trans Pacific Islanders endure in all different sectors. You know, with financial at 32%, at work at 46%, you know, at school 67%, on the street, just public discrimination was close to 70% as well. And so, you know, just personal worry of discrimination is at 75%, which is extremely high. And so when you look at this even deeper, and you look at how what their experience are in the healthcare system, a lot of this was sort of looked at the percent that were treated with doctors and nurses with different aspects of negative traits, such as not listening, less courteous, less respect, and they were high. They're at 46%, 45%. 24% thought that the provider was afraid of them. You know, and you know, I think this would be something that has to change, right? And so when you look at sort of why this may happen, there's different layers of oppression. You have racism and xenophobia and classism. They experience as just being part of the Native Hawaiian Pacific Islander community would lead to problems in regards to healthcare access, education, as well as economics. And then Queer and Trans Pacific Islanders have another layer of oppression of homophobia and transphobia. And that we see lowers resilience, increases use of a risk of drug use, depression, and underemployment. There's certain studies that show that almost 2 times the rate of depression happens in QTPI compared to their cisgender heterosexual counterparts. And so that's why it's really important that to combat this, QTPI orgs are important in leading sort of those areas, as they help provide a lot of the things that can sort of improve resiliency in these communities. And so this group that's led by sort of the Pacifica Village Initiative is this indigenous leadership group that's been kind of leading that charge. And so I'll run quickly through this, and here's where I kind of want to make sure we understand that they use an indigenization framework. Decolonizing is the dismantling of oppressive institutions, but the replacement of these institutions, can't do the same thing that the last system did. And it's really important that indigenization considers centering indigenous process of knowing, learning, feeling, and being for the marginalized communities to achieve equity. And so real quick, I think this is my last slide, that they were involved all the way through the process in that they identified the need to collect data. They selected their academic research partner. They helped design and develop the study designs and the survey instrument. They were responsible for disseminating to the community. And then they're the one that's going to act on it. They're the ones already providing direct services, and they've been doing this work before the survey came out. And so they're the ones who should be able to lead us through this. And then these are really references for anyone, and that's it. Thank you.
Matchwawan and Dr. Samuel. Now we will have Mr. Tofayano take the floor, and I think Gabe had did you have something to say, Gabe?
Yes, I did. I just want to again remind people that you can always submit your questions for speakers, and even though they may not be able to ask it or answer it immediately right after, we will have that discussion session so that they can be addressed in that session. And separately, for questions regarding recording of this, it is our intention that we will have a recording of this workshop on our NIMHD webpage so that you will have this information. Thanks again.
Thank you so much, Gabe. Mr. Tofayano, thank you so much for being here. And you have the floor.
Thank you. Let me share my screen here. And is this okay, Gabe? Okay. Tau manuia momo ona si le vinga male whaftai le atua mo le ne avano matano fie. O te whaftai mo so o tainga whaapea whaasoa I mataupo tawa mo tauto tanata Pacifica. Good morning, everybody. I'd like to first be thankful for the opportunity to present here on some proposed determinants to guide research in the Samoan population. I have no conflicts to disclose. I know briefly went over my bio. I just wanted to share also that I was born in American Samoa. We left when I was 1. I grew up in Las Vegas, Nevada, moved back in 2004 to American Samoa and started my my public health career there. Kind of labeled as an Afghasi or a half-breed because of my upbringing in the States, or even called like a coconut because brown on the outside and white in the inside, which is something I kind of have acclimated to because I think it fits with my role where I want to help kind of integrate or weave both Westernized and Samoan practices to help with research designs and improving health outcomes in our community. A little bit about our organization. Again, American Samoa Community Cancer Coalition. We are a nonprofit organization. We were established in 2004. These are a list of some of our programs. As mentioned, we did have a U24 grant that was funded by the NIMHD that helped to build research capacity and laid the foundation in what we currently do in research. We also have another project for artificial intelligence and machine learning for colorectal cancer. And then our last one is Pui Pui Malumanatu, which is the first R01 to be funded to a local organization in American Samoa. And that's for Alzheimer's disease and related dementia in our population. So when I was asked about this, talking about determinants, I've been working kind of on a framework based on the NIMHD research framework and trying to, again, weave some of our cultural perspectives into there. So this is probably more considered maybe a framework, but it does address the domains of influence on the NIMHD framework, I think, on the behavioral and social cultural side, but then also on the levels of influence it mentions a social ecological framework. But what I've kind of done here is I've added a Samoan cultural lens. What I do want to disclaim here, these are just proposed determinants. They have not been assessed or evaluated, studied empirically or otherwise. These are things that I've gathered from articles, books that I've read, our own research, and some of my own perspective. I'm also not a cultural expert. I consider myself a student in that. But these are also just to induce discussion and collaboration in terms of research in Samoa for Samoans in American Samoa or Samoan, and they're not to supplant anything. So I would start it again with the social ecological model. I'm not going to go through all these levels because we probably pretty much know all these, but I really wanted to see about how we can indigenize them. And where I felt was important, especially with Samoans, is to talk about who is it for. We talk about a collectivist community, and those to me start off with four kind of domains. And the first one is the Tanata Taitotasi, which is the individual. The individual is very important because what they do in with their personal lives is viewed and kind of scrutinized and under a lens on what you do in the village and the family. But it's your kind of worth as an individual is how you can contribute and support the ainga, which is the family. And then the ainga is where many of the beliefs and cultural practices are formed and utilized in the ainga structure. And then from there, it goes into the village. And the village represents the kind of the basic social and political unit of the society. And then from the it goes into the Tanata, the community as a whole, and that leads into community engagement and mobilization. We did a survey for COVID-19 knowledge, attitudes, and beliefs using the health belief model, trying to find out about vaccine hesitation at the time. And we asked questions about motivators to get vaccinated. And the top three motivators were for themselves to help with the family and the village. So I thought that helped to support. But also there is another Pacific Islander researcher, Melanie Anai, who coined the philosophy of Geo le Va. Geo meaning to take care of, and Va meaning the relationship. And the relationship between these four domains is very crucial. And again, how how they interact with each other is kind of the forms the foundation of the community, the collectivist community side. So that's where I thought it actually made more sense to have these four as the nucleus rather than on the SEM where they were kind of where you start with the individual, then go to the interpersonal, and so on and so forth. So again, these are the nucleus, and then it permeates the next level, which is what. So these are not in any particular order, but I felt that if you address these four areas towards research, that that these are pretty good ways to conduct studies in the island. But we start off with Bule Sili CDS, which is sovereignty, is that research is conducted that sees us as partners rather than subjects. This links to kind of what Nia was talking about, colonization. There's so many historical events in terms of research that have that have exposed our populations, not only Samoans, but other indigenous populations, the Havasupai Indians in Arizona. Think about other minority populations like the Tuskegee syphilis projects and so on and so forth. So we wanted to make sure about sovereignty, that there's equal access, and also that whatever data that is collected remains within the community. The next one is fa'aloalo, which is respect, that research is conducted in a culturally appropriate and safe manner. Culturally safe manner, the meaning that there is no hegemony between the researcher and the participant, meaning there's no power bias, that they come at to a equal level as well. And there are some frameworks and methodologies that help to outline this in Pacific Islanders and in Samoans and Tongans. One that comes to mind is the Talanoa framework, or even the Gailava that was mentioned earlier. Malama Lama, which is knowledge, understanding there are multiple ways of knowing and sharing. This is in terms of, we know with academia, gold standard, the dissemination of results is always about publications and peer-reviewed articles and journals and books and things like that. But that just isn't how our population shares knowledge. Nia, again, alluded to a little bit to it about it's done orally, it's done face-to-face, it's done in a respectful manner and in a way that that reflects the community needs. And then lastly, there's tatua, service. That research is done in the best interest of our people. And there is a Samoan proverb, oleale le pule ole tatua, which means the pathway to leadership is through service. And this kind of relates back to whatever the research is, it has to benefit the community as a whole, and find out what, and advance and share knowledge again, like I mentioned. So the last ring here that I'm going to mention is how. And quite simply, for us, that is through alofa, which is love. There was Leatawa, Dr. Robert Peterson, that stated alofa is akin to a universal force upon which all other themes and elements in Samoan life revolve around. Alofa is everything in Samoa and the critical feature of leadership, but this could also be used with research as well. So these are the three levels that we're working with, or that we've developed, and we're continuing to kind of see on what the next steps are, which are I plan to try to validate, but this is not in some kind of statistical meeting. It's probably gathering a purposeful sample of some like-minded people and have a discussion of these proposed determinants or frameworks and get feedback and make any kind of revisions. Next step from there is to kind of see if we can weave it into the NIMHD framework, similar to the Native Hawaiian and the American Indian Alaska Native framework. And then see if we can also administer it into some potential studies and programs and get some data to assess it as well. These are my references. And I would like to say again, Faftai Tele Lava to the committee and to all the participants here. It's my QR code if you want to scan for my contact information. Thank you.
Matchwawan and Mr. Tofaiano. Now we will have Dr. Keawe Kaholokua to introduce the discussants.
Aloha, mahalo nui to our awesome speakers, Dr. Mokuel, Dr. Samoa, Dr. Tofa Eono, mahalo nui. Now we'd like to also invite into this discussion our invited discussants for this session. And we have with us, joining us, our speakers is Tana Lepule. Mr. Tana Lepule is from the Pacific Islander Collective from San Diego. Also joining us is Dr. Andrew Subika from the University of California, Riverside. And also joining us is Dr. Tina Tavana from Brigham Young University. So mahalo to our three discussants that will be engaging our speakers and all of us as well, all of the other panelists, speakers and discussants that are joining us for a lively discussion around determinants of health.
And I'll turn it over now to perhaps Dr. Subika. You might get us started as a discussant.
Dr. Sabika, you are muted.
Aloha, everyone. Yes, thank you so much. Apologies for that. Appreciate it, Dr. Kaholokula, also Dr. Spencer, NIH and IMHD for inviting me to be a discussant. Really, this was some amazing chats. I've been told I'm supposed to just briefly introduce myself. I'm with UC Riverside. I do work with Native Hawaiian Pacific Islander health disparities, mental health, especially in substance use. And a lot of my focus is on doing culturally grounded interventions, trying to develop these in concert with Native Hawaiian Pacific Islander public. I think really that's about all the intro I like to give about myself. I am really interested in capturing some of the discussion points that people have on like upstream factors, because that came out very strongly in Dr. Mokuao's discussion, also in Dr. Samoa's discussion. And I was really taken with some of the things that Dr. Samoa was saying about, for instance, cutie pie, queer transgender Pacific Islanders, how that's really important to examine, but very understudied. So I guess my first question to lead some of the discussion is, when you think about the upstream factors, what are some other areas or even areas that we've already discussed that researchers can focus on that might have the greatest influence on actually changing health disparities over time? And one of the things that I always think about when I say this is also sustainability. When we think about what changes in upstream factors can actually have impact for not just the cycle of a grant or project, but for decades, maybe generations in the future. And yeah, so that's my kind of first discussion point.
Mahalo, Dr. Subika. Perhaps we can call on Dr. Mokuao to begin in response to your question.
You know, as I indicated in the presentation, I think much of our work has focused on the micro level factors or downstream, and then movement. I think I've seen visibility and movement up to even midstream factors. There is a lot of unexplored, unexamined, to be pursued areas within upstream factors. And I think that's where we should move. I think the people, participants in this workshop probably have the areas that they want to pursue on their own. And so I don't ever wish to overspeak them. But I think in the geopolitical arena itself, looking at root causes as to what brings about health disparities, rather than just only our interest in altering or modifying or changing personal beliefs and values on healthcare or personal practice on healthcare. What is it that is society-wide that we need to look at in order to make some of the changes that I think need to be seen in healthcare improvement.
Perhaps Dr. Samoa, if you want to add.
No, I agree completely with Noreen. But probably one thing I would sort of just put into sort of our thought space is looking at the social determinants of health from kind of that belonging and inclusion. You know, like, yeah, you're trying to fix sort of the downstream metrics of inequity, but, you know, to what endpoint? You know, like, are you trying to, because sometimes equity is not great, right? Like, if the baseline is not great, then you're just going to reach like another level of dissatisfaction. But I think optimizing those metrics, you know, by focusing sort of on the belonging, you know, like I think when we reported that there was high discrimination and high levels of poor and fair health, one of the things that the group mentioned was, how do we belong? Is, you know, and so that led to the conversation of, you know, you need more cutie pie doctors. You need more cutie pie nurses. You need more cutie pie in those spaces. And I think, NIA's Pacific Islander DPP is a great example of that. In that, not only are you trying to reach equity, you're trying to change it so that you belong, into that space. And so, like it went from sort of like taking the the normal goals of the DPP and going even further, pushing social determinants of health onto that. And so now what happens? I bet you the CDC has neon speed dial. That's how you go from sort of being involved to now belonging in that space.
Mahalo, Dr. Samoa. I think we all got neon speed dial. Maybe I could turn this question to our other speaker, Mr. Tofoeono. Do you have anything to add to that?
Yeah, I agree with Dr. Samoa, Dr. Mokuau. I just wanted to maybe add to something that we've been seeing and discussing more within our team is that it's with terms of like equity, those need to really be defined in our cultures and our societies, because it is kind of like a westernized term. And equity for one group does, like how Dr. Samoa mentioned, kind of that equity for one group might not be the same as for another group. I see that one there's like one image, a cartoon image about where they talk about equality and equity, where these cartoon characters are sitting on a box and they're trying to stand on a box and trying to look over over a fence at a baseball game. But some of these populations, to me, why are they standing on these boxes? Or why are they at this baseball game? Or those things. To me, those things are defined as on the westernized perspective, but not so much taken by on the indigenous population side or the minority side. So I think it's important that those get defined first and then build out whatever kind of intervention or study that you have from there.
Mahalo, mahalo. I'm going to now turn to our another discussant that's joining us, and get, and introduce herself. Dr. Tina Tavana, if you would please jump in here, introduce yourself, but also your thoughts and maybe perhaps a question you may have for the group.
Sure. Mahalo Kiave.
Mahalo.
Talafalava. My name is Tina Tavana, and I'm actually in Tonga right now. So if the internet goes out, I apologize. So I am a human geneticist at Brigham Young University. I'm also trained in neuropsychology, and I'm studying the genetics of Alzheimer's disease and related dementias in Native Hawaiian Pacific Islanders. I'm grateful for all of our speakers today, all of your knowledge that you've shared with us. I'm just grateful to be here in this forum, and grateful for NIH for recognizing the importance of bringing us all together. So I was in Samoa last week with Mr. Tofaiono. I'm in Tonga this week and then New Zealand next week, and really just trying to build a network of people to be able to bring us together and really learn from each other. So one of the questions that I would like to ask is, with such a low sample size of these unique subgroups of Pacifica people, what are some appropriate scientifically, logistically, and culturally tailored ways to conduct research in such small populations? And I'm grateful for kind of some of the talks that use traditional frameworks to be able to work in these populations. So yeah, just want to open that question up to anyone that would like to take it.
Let's work backwards here. Mr. Tofaiono, do you have a thought?
Yeah, thank you for the question. I think this is a tough one, especially because we're doing studies. I always get worried that we're going to reach like research saturation within our community. But you like how Tina was mentioning, we have to do sampling size, statistical power, and things like that. But it's a good question because I think when within the community, I mentioned about like at least the Talanoa framework where you go in with most like a community-based participatory approach and identifying who your traditional partners are and faith-based leadership and things like that to get recruitment. But I think also to kind of address some of that issue is that there's more collaboration between oh great, I think I froze. Sorry, I think I froze there.
No, you're good.
What I'd like to see is like if there's more collaboration between Samoan groups in the islands, and we're doing research with Samoan groups in the States. I think that's one way to help bridge the small population size, because we talked about there are more Samoan, more.
Okay, now he did freeze. Well, while we're getting him back, how about we move on to the next speakers? Dr. Samoa Mokuel, do any of you have a comment to this? And then I see that Dr. Fernandez has her hand up.
Maybe after the speakers give their comments, we just have some questions in the chat. So,
Okay, great.
Thank you.
Noreen?
You know, you might look at secondary data analysis, which is perhaps national, and that would have larger sample sizes. But, you know, it is absolutely true. The census on our populations are small. So, you know, I also think it's valid to do qualitative or mixed method, qualitative, quantitative studies that will yield results with validity and reliability as well. So sometimes when we think of research, we think of huge sample sizes. I'm not so sure that's always the only way to go when we're examining some of the issues that we are within our population. If I may, Calvi, I want to go back a little. You know, we have a really humble group of presenters and determinants and discussants. And I wanted to say one more thing about upstream factors. You know, when you look at attempting to have impact, and I really do say we're still moving there, and it's still an area of great unknown, although we're beginning to identify those factors in that sphere. People on this call are so greatly involved in that movement already. And I'm going to call out Dr. Samoa, who is a member on President Biden's advisory committee for Asian Americans, Native Hawaiians, and Pacific Islanders. So he has a direct way and access to bringing about policy and regulation change at the federal level that will impact all U.S. specific jurisdictions, as well as our people in the various states of the United States. So, you know, while we're considering the areas in which we want to have impact for macro level upstream factors, I think we have to think about ways to do it. And almost every person on the determinants panel is greatly involved in networking, either at the federal, the Pacific Island, or the state level that can bring about these changes. So there. Mahalo.
Thank you. So in full transparency, so on this meeting, I do not represent the commission, but I can speak about some things that they've already done that are public record now, which goes right hand in hand with what Dr. Mokuel was talking about. But so Tina, to answer your question, you know, the secondary data analysis is oftentimes used to try to find invisible communities. What's happening is that we don't have access. Due to a lot of statistical regulations, a lot of the federal agencies don't release their data. And so we don't even have access to it. But, you know, based on some recommendations and some work that the administration was doing, there is a catalog of what databases do have disaggregated data for researchers to tap into to do secondary data analysis. It's not completely comprehensive. There's a lot of key agencies that don't have disaggregated data. So it's really important that we continue to put our foot on the pedal and keep asking for it, because a lot of these agencies represent key sectors. As far as like qualitative data, the mixed method has been very crucial to getting a lot of key information for NHPI social determinants. And this is kind of where I believe like you start with the community. You know, Puni is a perfect example of that with Kula, that you know a lot of it is methods that we know that we'd had to do before they were popular, like the snowball sampling method, you know, where you take experts in a community and you know who already know their geographical locations, who know how to access them through whatever networks they're part of, to get you know access. And so you know this I really loved it when Dr. Titozo said you know engagement is passive. Yeah, you have to be part. You have to be part so that you know who you have to talk to, because even though you use these like nested clusters, sampling designs, or you know you engage in like snowball sampling methods, it starts with the community. You have to go there first. You know, as a basic scientist, you know you'll understand that eventually you're going to get there. You're going to have to get to that point where you have to lean on the community wisdom to get the information that's required.
Mahalo. So before we go to our third discussant and introduce Mr. Lepule, Dr. Fernandez, we have a few questions from the audience.
We do. We have, it looks like we have about 3 questions. So I can just go through one at a time, or we can answer one and then skip, go to another one later. But you just let me know. The first one is from Karen. Upstream factor, is land use and ownership and our water rights a significant issue? Use of land for Hawaiians, for communities, commerce, and health of land and people. Does belonging relate to ownership and control of lands?
Mahalo for that question. Would any of our speakers, or even our discussants, would like to address that issue around water rights, access to water, and so forth, and its effects on us, our well-being and health? Is that, Dr. Fernandez, is that the question, just to clarify?
Yeah, upstream factor, asking, is land use and ownership and our water rights a significant issue? Use of land for Hawaiians, for communities, commerce, and health of land and people. Does belonging relate to ownership and control of lands? Is the question from Karen.
Dr. Mokuau?
Anything related to the Aina for Hawaiians is a critical matter. And if Hawaiians do not have access and utilization in a way that is culturally appropriate, then that is a barrier to health equity. It is a barrier to sustaining life the way that is within the cultural identity of Native Hawaiians. And so if the question is that a macro level upstream factor, definitely. I think there is in Hawaii large discussion on Aina and rights of Hawaiians with access, but we are not near where we need to be in order to have it make a difference and impact health for this people. I am actually going to look at Keawe because I know Keawe has a perspective he wants to share as well on this.
Yeah, no, I want to, mahalo, Dr. Mokuau, that was excellent. And I'll just add to that and just say, you know, for most of us in the Pacific, I think all of us in the Pacific, our relationship to the land is more than just, it's ancestral, it's a genealogical relationship. It is literally an elder sibling. And so it's a relational thing for us, much like an auntie or uncle or grandparent. The Aina is part of our families, and thus what the health of our land affects us as a people. And I think you'll hear more about that later. Actually, Dr. Mapuana Antonio is doing some really excellent work developing measures to look at cultural constructs. And one of them is our relationship to Aina and its effects on health and well-being. So I would ask that we hold off for that discussion and we can learn more about these cultural concepts. But definitely, I agree with Dr. Mokuau, it's one of those really upstream factors. I want to make sure we get to our third discussant, but I am going to come back, Dr. Fernandez, for those other questions. But I do want to introduce Mr. Tana Lepule. Mr. Lepule, aloha. Take it away, Tana.
Thank you. Talofa everybody. Tala Lepule here in the Big Island of San Diego. I don't know how I ended up as a discussant, but I'm here and I'm going to take advantage of it. I think this is a very teachable moment. In my quick scan of the audience, doing my Google searches, it looks like we have a combination of community, academia, and federal agencies. To that point, I want to address this to our amazing speakers, our presenters, really to address something systemic. And each of your presentation, you shared some of the barriers in the work that you do. My discussion question would be, having these folks in the room, specifically our federal agencies, our government, what suggestions do you have to address some of your specific barriers that you shared in your presentation? And I say that from the perspective of an advocate who appreciate opportunities, but at the same time, we ask as we get funded for behavior change on the community side. Well, I would like to kind of just see how we can assist our federal agencies on working and possibly adjusting their systems. And then some of our presenters already shared how they would frame or tailor it to our ways. So my question would be, to the barriers that you had mentioned, what are some recommendations that we can share with the folks in the room? Thank you.
Mahalo, Mr. Lepule. So to our speakers, what are those hard recommendations that you want to put forth to our NIH colleagues and to others that are joining us? If NIH, when NIH considers what type of research, what kind of research is important to our communities to advance their health and well-being, what are those recommendations you would make from your perspective, especially as it relates to determinants of health?
I'm going to begin with if I may, with a really broad level, Tana. So mahalo nui, thank you for the question. I think if I went back to my last slide in my presentation, and then if I could borrow from some of the other thoughts that you have all shared, it would be to listen to all the federal agencies who want to be a partner and a collaborator with our people, just to listen to their stories, to better understand who we are, where we come from, what we do, how we live, and then to invest. And as everybody has said repeatedly, to include, to listen, to invest, to include, in order that we can support the kind of research moving forward that speaks to what our communities want and need, rather than what to others think we want and need. So if I could be as fundamental as that, I feel like I'm maybe repeating what we all have said, but I hope that still stands true. Mahalo.
If I may summarize that, I think that's excellent. As far as recommendations, I'll use the acronym LII, right? So listen, invest, and include. And I think that's been the theme with our keynotes, for example. Have been saying that. I think it's been said throughout. So the recommendation you're putting forth is li'i. So, sorry, it's a Pacific thing. Li'i in Hawaiian actually means small, but not insignificant. So mahalo, Dr. Mokuau. Others, Dr. Samoa, do we have Mr. Tofaiono back?
I think he was having difficulties, so he was going to log out and log back in. I think he's not back yet though, but he's working on it.
Thank you.
No, I think that's it. But I think there's a lot of metrics to go for. Definitely the employment breakdown of the NIH is not inclusive. It doesn't mean that we have to believe in quotas, but you definitely want to see some effort, either in like development or training to try to improve those numbers. The other part is like the RFAs. There was mention about sort of how the distribution of those RFAs have panned out. And, a lot of that lacks investment. One can, I think 10 years ago, people were just kind of throwing their hands up. It was like, oh, they're just not applying. But, there was no investment to sort of culture these NHPI researchers. There's more coming out, but, are they in line with sort of getting research funding from the NIH? I don't know. The other part is what type of RFAs are out there. There's not a lot. I mean, I hope that's going to change with some of the changes in the NIH, but there's not a lot of RFAs that spur innovation based on indigenous wisdom. Granted that the NIH is very system and disease based, so it's hard when you look at something that's organized in a downstream fashion to do sort of that kind of upstream work. But we're here for a reason. We're here because inequities exist, and so I think if we're going to make any movement on that, then it requires sort of some type of reformation of how we're distributing these RFAs.
Hello, Dr. Samuel. Dr. Fernandez, is there a question we can entertain at this time?
Yes, there is. This question is from Jimena or Jimena. Apologies if I mispronounced your name. Question for the collective. Most times our funding to conduct research and intake come with timeline barriers. We know as NHPIs, we cannot timeline trust building. How do we indigenize this process that feels comfortable for us and community while getting to the root causes of health disparities? And then there's just a second part of this question to follow. What are the aftercare methods we can provide to community once this research has been done?
I'm going to ask that our discussant, Mr. Lepule, could elaborate on that and get us going with a larger discussion there, because I know Mr. Lepule has a lot of thoughts on the subject matter here or this issue.
My apologies. What was that question?
Well, the question was really around, what I'm going to summarize that, funding often is not enough to adequately engage our communities and do the kind of community level work that we need to do. And there's also trust issues that the question about trust. And I know, Mr. Lepule, a lot of your work with the SEAL initiative and others have really tackled these complex, these important issues. So I'm just wondering, as a discussant, would you like to get us going on that as we open it up?
Sure. Again, it goes back to systemic, right? You can create grant opportunities and send it out, but is the grant opportunity specifically with the community's insight or gifts in mind? Also recognizing some of the limitations from communities who, organizations from small to very seasoned, acknowledging that sometimes the community organization that doesn't have a long fiscal history are the best implementers of such interventions. So I think, going back to, I think it was LEE, was that the acronym? Is if I could just share with our federal partners or any funders to follow that concept or follow those principles, that would be a more meaningful kind of relationship, not just a contract, but an actual relationship on addressing some of these social determinants of health. So that would be my little soapbox moment is, requesting that our federal agencies get to know us, show some of the behavioral changes from a systemic point on that end to show that you're looking to, work with communities. Because I think communities have done their fair share. So I think just acknowledging this partnership and not be a contract, but more of a relationship. Thank you.
Let's open it up to others. Any thoughts on this? So of the LEE, the invest and the include part seems to be a big one. And going back to the question that was posed, is the investment a fair investment given the work that needs to happen? And are communities and NHPI stakeholders included in decision making? That's what I was hearing. Any other thoughts?
Could I chime in here?
Hi. you know.
Hi, so I think part of the question too was on timeline, right? Timeline in building trust with our community. And we had just put in a grant where I had to have several letters of support from community members, community leaders. And again, I'm trying to build this network, and it's amazing how our community comes together when we need to, right? When we understand what it is that we're trying to do. And even just from meeting each other for the first time, I think we're able to just, trust is so important. And sorry, I'm trying to, so I reached out to a few nonprofit organizations in different states where there are large populations of Native Hawaiians and Pacific Islanders. And even just at the first meeting, we were both able to feel the mana, right? Feel the love, the aloha, the alofa that we have for each other and for our communities. And that in itself was able to build trust. And so I know that with NIH and other funding sources, they always have this timeline that you have to be on, but it's been amazing at the level of trust that we've been able to gain and connect with other people just because of who we are, which I think is something that is a wonderful thing that about our culture.
Oh, Dr. Tawana. Dr. Subika, I would also, bring you back into this discussion because you do a lot of work around mental health. And as our keynote, Dr. Aitolto mentioned, mental health issues is one of the top priorities in our communities, especially since COVID. And you work a lot with NHPIs on the continent as well, I believe, as in Hawaii. So any thoughts for you? You want to add to the conversation around trust building, whether funding is at appropriate level to do the work we need to do, or around even community capacity building that was mentioned by Mr. Lipule?
I think I'll address the trust building. Thank you for that, Dr. Koholokula. It's so much in my experience about just being open to being responsive to what the communities request and tell kind of researchers and NIH. And I don't know that it's always easy to be that responsive. One example is kind of, the opioid crisis is big on the continent. And then it became a big issue, in Hawaii. And, to what degree were we, as researchers able to respond to something that was, killing a lot of people on like the Big Island, where I'm personally from. And so when we tried to pivot to that, it became work on homelessness because NHPIs have extreme disparities, especially Native Hawaiians, with unhoused and homelessness in their own homelands. And I think that's kind of, in my experience, how you develop trust, like over the long term with communities, is you can pursue something like, mental health, but when it becomes kind of a public health crisis in different ways, like COVID-19, suicide, to what degree is funding going to be there to go in other directions? And that's where my concern is often probably is, are we getting enough funding towards the priorities that the community says, especially around mental health, and that's now bleeding into substance use. And there's not a ton of research yet. So hopefully that's something people can push.
Thank you. And being nimble and going where the community needs to go and where the research takes you. And sometimes it takes you on a different path or a connected path. I want to be mindful of time. I do want some time to summarize this session, but I think, do we have any more, Dr. Fernandez, questions from the audience that we could?
Yeah, there's just one more that I see from Kekoa. Mahalo nunui to all the speakers and panelists. Really mahalo all for the emphasis of Aina connectedness. Regarding data, in a time when many populations are talking about data disaggregation, how can we as Pacifica researchers be respectful in balancing the acknowledgement of our diversity while also recognizing our strength in numbers and our shared ancestry?
Mahalo Kekoa for that excellent question. Actually, we have a whole session on methods, and one of our speakers will touch on data. But so I would welcome all of you to please join us for that discussion. However, perhaps real quickly, does anyone here have a thought or response for Kekoa? Okay, because we do have some experts in methods coming up. In particular, Mr. Calvin Chang from UCLA will talk about a lot about data disaggregation and so forth, and issues around data ownership. So at this time, I would like to just quickly, if I may, let's discuss this. Do you folks have any pressing questions for the speakers?
Excuse me, Kayave, it looks like there's one more question, but if there's not, then we can respond after. So your call.
Yeah, discussants, do any one of you have a burning question that must be asked, especially around determinants? If not, we'll go to the, okay. Okay, Dr. Fernandez, what's the question?
Sure, and this is maybe also from Karen, maybe follow up also from before. Does land ownership and control of land use influence social determinants of health? Is the concept of ownership and control of land impact health, both mental and physical, on island areas? Does control of water and other resources impact this?
Wow, powerful questions. Speakers, any thoughts on that? I'm sorry, Dr. Mokuel, to pick on you on this, and it's because I know it's coming from a Hawaiian perspective there, but others are welcome to join in.
So the answer is yes, that there's clearly an impact on land sovereignty, water rights, access to ocean, access to sacred places, clearly an impact of lack of access to the health and well-being of Native Hawaiians. But if I can go back to the broader cosmographic perspective that Keawe offered, you know, for Native Hawaiians, everything is intricately linked. So the Aina, the spiritual realm, and the Poe, the people, if they are not in harmony, if there's not that linkage, if there are blocks, say there, then there is no health and well-being. There is no pono, there is no right way forward. And so when we view it in the framework, it looks like the uppermost sphere. But if we viewed it from a Hawaiian worldview perspective, which I think is comparable to other Pacific Islanders, then it's all intricately related to identity, to well-being, and to the collective. I think we can get into more specifics on how people are moving towards appropriate land access, water access, rights to worship in spiritual realms and sacred places. But that would be deeper channels of the overall worldview.
Mahalo, Dr. We only have 2 minutes left. And with that, I would just like to quickly, well, first of all, mahalo to our speakers. Excellent presentation. And I think in sharing your perspectives on determinants of health, you also shared some really great examples of research being done in our communities, directions that we should consider taking. You know, all of you, I think, touched on those upstream factors that are important. I believe all of you touched on the issues of racism and discrimination that we face and how they intersect with other factors related to social determinants of health. We talked about culture and land and how land and culture is for Pacifica people are part and parcel of who we are. And it needs to be considered as factor or determinants of health. And then we got into this discussion around engaging our communities and what we term LII, acronym for listen, invest, and include. And it was kind of the theme, I guess, throughout most of the discussion in many different ways. And that we need to be able to listen. We want our federal colleagues to listen to our stories, listen to what's important to us so they can better shape research opportunities that are meaningful, sustainable, and culturally relevant. The other issue is the investment, and questions came up. Is the investment adequate? How do you invest in research that requires strong community engagement and requires time, but also requires trust? And that's where we enter into inclusion. We need to include our Native Hawaiian Pacific Islander stakeholders in the research, in designing perhaps research. And that's why all of you are here, to help our NIH colleagues understand what is needed going forward. So mahalo to all of you for sharing that. We asked, we need to move on in the agenda, and I'm going to turn it over soon back to Dr. Lai to get us moving. Want to mahalo Dr. Fernandez for making sure I address the questions coming in from our chat. And again, mahalo to our excellent discussants. I wish we had more time. And we do hope, again, you join us for the breakouts and for further discussion. Mahalo.
Thank you so much to all the speakers and the discussants, and to Kiawe and to Angela for helping to moderate that session. We're going to now go into our break. We're running a little bit behind, but we'll still provide 10 minutes for this break. And so I now have on my clock 2:49. I'll be gracious because it's been a while. Let's meet back at 3 p.m. and then we can resume for our session 2. Thank you. Hello and welcome back, everybody. We have 3 p.m. Eastern Time, 10 a.m. Hawaii Standard Time. My clock. I just, again, want to thank you all for your participation, for all the speakers and discussants. And I now want to ask Lieutenant Commander and Dr. Adelaida Rosario to please start our second session. Addie, please take it away.
Thank you, Gabe. Half a day to all. I'm Lieutenant Commander Ali Rosario. I'm with the Office of the Assistant Secretary of Health at Department of Health and Human Services. I'm grateful to be a part of the coordination of this groundbreaking workshop, and I applaud NIMHD for its continued responsiveness to our Native Hawaiian and Pacific Islander community and their commitment to working with us to mitigate the disparities that continue to plague us. It's a privilege to be here today with you all to do right by those who came before us and to those who are coming after us, so we can ensure not only more optimal health and wellness, but a more explicit seat at the table to reclaim and determine our own destiny in all aspects. So it's my pleasure to introduce the speakers of our second session, Mechanisms and Processes of Health Outcomes. Our first speaker is Dr. Christina Holub, an associate professor and chair of the Department of Health at California State University, San Marcos. Dr. Holub's research focuses on developing behavioral interventions to reduce health disparities through academic community partnerships. Her formative work with the Native Hawaiian and Pacific Islander community in the San Diego, California area has resulted in 2 community-led pilot physical activity studies. Currently funded by an NIH R16 SURE Award, Dr. Holub's research collaborates with the NHPI and Latino communities to create and inform new innovations to reduce health disparities. Our second speaker is Dr. Alika Mauna-Kia, who is a professor in the John A. Burns School of Medicine at the University of Hawaii, Manoa. He has developed and applied novel high-throughput genome-wide technologies that survey DNA methylation and histone modifications and has discovered novel roles for DNA methylation. As a Native Hawaiian scientist, Dr. Mauna-Kia combines his expertise with community-based research experience to better understand the socio-ecological determinants that influence epigenomic and gut microbial pathways that underlie the progression of diabetes to identify novel biomarkers that enable prevention. And finally, our third speaker, Dr. Sung Shim Orlani Park, is an associate professor and cancer epidemiologist at the University of Hawaii Cancer Center. Her research focuses on identifying behavioral, environmental, genetic, and epigenetic risk factors that contribute to the racial and ethnic differences in cancer risk. She is the project leader of a program project grant that aims to understand the mechanisms underlying the racial ethnic disparities in lung cancer risk. Dr. Park also co-leads a study that will build a new cohort of Asian American, Native Hawaiians, and Pacific Islanders so that populomic approaches can be used to identify health determinants within the subgroups. A warm welcome to all of our speakers. So Dr. Holub, please proceed in starting us off with the mechanisms and processes of health outcomes.
Absolutely. Let me get my screen settled here. Can everyone see my slides? Yes.
Yes.
Okay. Thank you so much. Good morning or good afternoon, depending on where you are. I'm here in sunny San Diego. It was raining previously, but it's sunny, back to sunny. I'm here at Cal State San Marcos. I also coordinate the PIC Health project, Pacific Islander Community Health. Thank you so much for having me here. I'm very grateful for this opportunity. So in this workshop series, we just heard from our colleagues on social determinants of health, and we understand that environmental conditions, where we're born, live, learn, work, play, and pray, do have an impact on our health. And tomorrow we'll hear more about methods and specific cultural interventions to improve NHPI health. And I see our current session as kind of a connection between the two, more specifically around mechanisms and processes of health. And I'll be covering psychosocial and behavioral health. And as we've heard throughout this morning, we know that some of the leading causes of death for Pacific Islanders are cancer, heart disease, stroke, diabetes. It is also important to note the social and behavioral factors that contribute to those health outcomes. So whether improving them or making them worse, such as nutrition, physical activity, access to care, stress, and managing mental health, as we know, is a priority and a growing concern. But what is it that we need to know before we get to the intervention or the prevention piece or building our health programs? We do know that the social environment and family are at the heart of Native Hawaiian Pacific Islander lives. So looking at this specific model, social networks and social support, we can see that there are many pathways from our social environment to physical, mental, and social health. There's one pathway that's straight from our environment to health that leads direct. And in this pathway, a sense of belonging or assurance of self-worth has that direct impact. Your social environment can also influence individual resources, access to new contacts and information, perceived control, as well as organizational and community resources and community empowerment. This third pathway, one that I'm particularly interested in, is how your social environment impacts stress leading to health. We know that this influences exposure to stress. So whether you're exposed to more stress and poor health outcomes or less stress and better outcomes. We also know the biological pathway between stress and especially chronic stress to health is through cortisol, the primary stress hormone, which impacts your body and your natural complex systems in preparation for fight or flight. So we know that chronic stress and mental health are very important in this pathway to health. And in this last pathway, your social environment impacts directly health behaviors. So whether it's your risk behaviors or the preventative health behaviors. And of course, ultimately all impacting your physical, mental, and social health. And this impacts or influences incidence of disease and recovery. But looking at this particular model, there are many models. So which is the right one for Native Hawaiian Pacific Elder Health? Is there a right one? There are other models when we're thinking about behavior change or changing specific risk factors. So here's theory of planned behavior, where attitudes, norms, and perceived behavioral control are important, just as the intention to change behavior. But as you can see here, you can bypass intention. So I think we all have this experience where, we want to eat healthy, we want to do physical activity, but even if we intend to, that doesn't mean we always will. So this kind of helps explain that. But we also have the health belief model. So our preventative health behaviors depend on perception. Using cancer screening as an example, if there's no perceived threat, you don't feel that you have this susceptibility, then that's going to help decide whether you do or don't get cancer screening. Another way to look at this might be, maybe it's our stages of change or how we go through the process of changing our risk behavior. So whether it's pre-contemplation, you're not thinking about change, to moving towards thinking about it, preparing action, maybe relapsing, but hopefully ultimately maintaining and continuing that health behavior change. But there are a lot of models and frameworks to consider. I think this has been brought up already several times, a socioecological model. And it really does look at our individual characteristics, relationship, community, and societal factors, each at its own level, but also as an iterative social process. In my personal postdoc journey, trying to better understand NHPI health, I was really inspired by the Piliohana project led by Dr. Keawe Kahulakula. And I adapted that for my work in San Diego with PIC Health, Pacific Islander Community Health. So you can see it is important to incorporate socioecological factors, community, family, individual influences that again impact your risk behavior and ultimately morbidity and mortality. So going along with an example from some of my work around physical activity, community influences, you can see here, we worked with a Tongan-owned gym who also had resources for getting body fat in the dunk tank. Family activity was important, and also mental health and stress. All of those leading to whether you, eat healthy, participate in physical activity, and again, all of those risk factors leading to a lot of the leading causes of disease in our communities. And so this kind of leads me more towards the recommendations that I've been thinking about. We do have a lot of shared values, but it's also really important to think about context, environment, and time. So whether it's Hawaii, California, Arkansas, Utah, whether it's before the pandemic or after the pandemic, we see how we engage in interventions and health programs very differently. So I think those are very important to consider. And I'm really happy to see that there are a lot of new frameworks being developed, but we definitely need to see more that are culturally relevant, and we need to adapt them or create them, test and validate. And in order to make sure we have a well put together framework or conceptual model, we need to make sure that we're actually measuring correctly as well. So developing and validating appropriate measures. And I really loved hearing the acronym LII, listen, invest, and include. And that kind of speaks to my last point of, and the title of my presentation, how do you determine the right path? And it's really through co-creation, co-designing, and working in true partnership with communities. And that's really been the core value in a lot of the campus community partnerships that I'm engaged in. So because of that core value, I did want to share some voices and some thoughts from the San Diego community.
Health is important to me because of family. Because it could be balanced in your mind, body, and spirit.
So I can be here for my family.
Because I value my mental and physical state. I want to have a better quality of life to spend time with my family and friends.
Health is all about the quality of life. If you want to have a quality of life, you take care of yourself from inside out.
Because health is helping us all move forward and make things right so that we can preserve who we are and the culture. Mina mina au ke ola kino mai kati.
Hoya kaya, te fili mau dele. I mean,
Ina pa maule za anak net. Koho au ike ola kino. And that's why I pick health.
Thank you very much. I always like to make sure I'm including community voice. And again, I really appreciate LII and thinking about academic community partnerships. I have my information and email there. If there's any other questions outside of the work session. So thank you again.
Thank you, Dr. Holub, for that. We'll go ahead and now open it up for Dr. Alika Maunaki.
Aloha mai kākou pākahi. My name is Alika Maunakea. I'm honored to be part of this workshop among many esteemed colleagues. Mahalo to NIMHD for gathering us here today. In this short presentation, I'll discuss some examples of work we are pursuing to understand and address health disparities in Native Hawaiians and Pacific Islanders. And in doing so, I hope it will offer insights regarding the unique challenges and opportunities of biomedical research in this indigenous population. Now, Native Hawaiians of today are descendants of ancient Polynesians that migrated out of Southeast Asia and navigated the Pacific. We intentionally sailed on double-hulled canoes, settling Hawaii around 300 AD, and developed a sophisticated society that was completely self-sufficient and sustainable, albeit isolated for over 1,000 years. And you heard from our previous speaker, Nia, how healthy our ancestors were. However, following first contact from the Western world, Native Hawaiian population suffered a steep crash, largely due to introduced infectious diseases to the point that we nearly went extinct. We were around 40,000 by 1900. Yet due to waves of immigration from Asia, other Pacific islands, Europe, and America, and interracial marriages, the Native Hawaiian population rebounded. Despite this rebound, the population suffered from abrupt and severe ecological changes that resulted in social cultural trauma, including these listed here, that still affects us. But as this population grew, Hawaii today is the most ethnically diverse in the nation, with a diversity index of 76%, according to the census. Although we are quite diverse and admixed, our unique culture, foods, practices, philosophies, life ways, and language, which were on the verge of collapse, experienced a renaissance in the late 70s. I mention this because the resurgence and reclamation of cultural practice and pride among Native Hawaiians, and including the Pacific Islanders, is key to improving the health of this indigenous population, where health disparities currently persist. While Native Hawaiians and Pacific Islanders make up about a fourth of the population in Hawaii, their mortality due to chronic diseases such as diabetes, which I'll focus on today, is over 3 times higher than that of the state overall. The higher prevalence of diabetes happens at a younger age among Native Hawaiians and Pacific Islanders than any other ethnic group by about 10 years on average. Why is that the case? Risk factors such as income and obesity appear to be linked to this, and we're only starting to understand how race and ethnicity may determine social environments and experiences that may impact gene function throughout an individual's life, and epigenetic mechanisms, which I'll focus on today, might explain these interactions. But I want to mention here that although epigenetics is relatively new to the field of biology, the concept that environment impacts health is nothing new. In fact, Native Hawaiians have for centuries not only understood this concept, but applied it to their daily lives. One example comes from our Olelo No'eau, or wise sayings like this one, "Ipa'a ke kino o ke keiki i ka la'au," meaning let the body of the child be solidly built by the herbal remedies, which was said of Hawaiian healers that would prescribe certain herbs in the diet of pregnant mothers with the idea that the constituents of the herbs would help support healthy development of the child in utero. The concept extended further, and it was thought that by doing so, it would help prevent the child from developing adult onset disorders later in life. Now, there's a growing appreciation in our field that gene-environment interactions might better explain the etiology of health disparities than genetics alone, and epigenetic processes may provide a possible mechanistic explanation for generational health impacts that's influenced by social environments, which is compatible with the Native Hawaiian Pacific Islander perspective of holistic health. This would mean that the origin of diseases of health disparities may largely be epigenetic rather than genetic in nature. One major epigenetic mechanism we study is called DNA methylation, which is a chemical modification of specific cytosine bases that make up DNA but doesn't affect the sequence. In normal development, DNA methylation patterns throughout the genome can be highly tissue and cell type specific, which I observed can be evolutionarily conserved across species. However, there's also significant variability in these tissue-specific DNA methylation patterns across individuals. Yet so far, it's unclear to what extent DNA methylation variability accounts for health disparities. Now, given the link, because of its cell type specificity, it's important to study epigenetics at the cell level to better understand its functional relevance. And given the link between inflammation and diabetes, my lab focuses on studying the epigenetics of monocytes, cells in your blood that play a significant role in inflammation. Depending on the environmental factors and prior DNA methylation states, these cells can either adopt a pro-inflammatory state, which can promote insulin-resistant conditions and leads to diabetes, or the cells can become anti-inflammatory, which regulates healthy metabolism. We're now examining whether the variability of DNA methylation in these monocytes account for diabetes disparities and measuring how much of that variability could be explained by upstream social and environmental factors using the multi-ethnic cohort study, which is the largest prospective cohort in the US to include Native Hawaiians starting in 1993 in Hawaii and California. It covers 3 major ethnic groups in Hawaii where importantly, blood cells were preserved over 20 years. From a subset of healthy individuals in this cohort, we observed that Native Hawaiians have a higher insulin resistance and higher number of circulating monocytes than other ethnic groups. We then examined the variability of DNA methylation in these monocytes. Now, this is unpublished data showing significant DNA methylation differences between individuals that eventually progress to diabetes compared to those that remain non-diabetic over a 20-year time frame. This heat map shows these differences where Native Hawaiians are clearly separating from the other 2 ethnic groups in green. And it's a visual of what we consider to be an epigenetic signature of diabetes risk, since these are all non-diabetics. And this data can actually be used to explore for prevention. Now, interestingly, we found that in another study, the monocyte population is actually expanded in clinically diagnosed diabetic individuals. So we believe this signature is important and functionally relevant in disease progression. We also identified ethnic-specific DNA methylation patterns across 3 main ethnic groups shown here, and the patterns are so specific that it separates the ethnic groups fairly well, with Native Hawaiians clustering on this end in green, whites on the other end in pink, and Japanese Americans in the middle in purple. Principal component analysis of this data showed remarkable separation of methylation patterns between the ethnic groups, basically telling us that at these sites in the genome, the methylation patterns are not only ethnic specific, but for some reason, they're much more variable among Native Hawaiians than the other 2 ethnic groups. We also found that these differences were enriched in genes involved in immune function and overlapped with those that relate to disease, diabetes risk. We and others are observing the importance of these monocytes in obesity and diabetes, but these cells aren't long-lived in your body and have to continually be replaced. They come from hematopoietic stem cells, or HSCs, residing in the bone marrow, and DNA methylation regulates their differentiation. We compared HSC and monocyte methylation states at these ethnic-specific sites and found that they did not correlate in Native Hawaiians, but oddly showed a higher correlation among whites and Japanese Americans. This and other data suggest that monocytes in Native Hawaiians that are derived from HSCs are already adopting an epigenetic landscape that's shaping the trajectory of the cell's functional potential towards an inflammatory phenotype that predisposes them towards diabetes, where monocytes in whites remain more capable of adopting an anti-inflammatory phenotype, monocytes in Japanese Americans in an intermediate state. We think this is the first example of an epigenetic predisposition to diabetes among Native Hawaiians. So we're starting to see that epigenetic patterns can be ethnic specific and that there are adverse patterns which associate with inflammation and diabetes. Now, are these patterns functionally important and are they reversible? We asked these questions in a pilot study where we partnered with Native Hawaiian serving community-based organizations listed here, such as Kula Nona Po'e that you heard from earlier, who facilitate a diabetes self-management intervention that includes social support. Now, without going through all the details listed here, I'll just say yes, adverse epigenetic patterns are functionally relevant to disease, in this case, in regulating inflammatory states of monocytes in diabetics, and yes, they may be reversible, in this case, remarkably so, by lifestyle factors where adverse epigenetic states normalize after the intervention and associated with reduced inflammation. Now, to identify the source of epigenetic variability, we recruited a new cohort of NHPIs in what we call the Hawaii Social Epigenomics of Early Diabetes Study. We applied an interdisciplinary, community-based participatory research approach to gather social ecological data at the neighborhood level, interpersonal level, and individual level, which includes biospecimens that are not readily available among NHPIs, where we examined other biological features related to health, including the gut microbiome, which is also affected by environmental factors. Now, similar to epigenetics, we observed ethnic-specific gut microbial taxa that associated with diabetes or obesity among NHPIs, whites, and Asian adults in our cohort, which was also linked to systemic inflammation. Interestingly, we confirmed prior studies showing that decreased microbial diversity corresponded generally to poor health, such as to diabetes, but this only applied to whites and not NHPIs and Asians in our cohort, which is unexpected. We also found differences in intra-individual variability of the microbiome among NHPIs and other ethnic groups. And surprisingly, we observed an increased proportion of NHPIs with accelerated biological aging, meaning they're aging faster biologically than their chronological ages, which is what we measured with using epigenetic data, where social factors such as education level was actually protective against in NHPIs and Asians, but not in whites. Now, without going into detail, these data and others that we are collecting are helping us to determine how the microbiome interacts with epigenetic regulation of immune cell function and biologic aging, which we think is an important driver of diabetes and other chronic diseases and offers new avenues for health disparities research. Now, finally, some key points that are emerging from our studies is that Native Hawaiians and Pacific Islanders are biologically distinct and diverse, even within their own subgroups. And so we cannot apply guidelines or recommendations around health developed in other populations to NHPIs and expect them to be as effective. In addition, higher prevalence of disease conditions coupled with a greater biological variability, ethnic-specific differences, and relationships with social factors in NHPI populations actually can enable novel discoveries, including our ability to tailor interventions. We would not have known this if Native Hawaiians and Pacific Islanders were not included in these studies. So representation of NHPIs in research is critical to better understand how disease develops and how we can best address and enable prevention in our community. To do this, we're currently ramping up community-led NHPI populomics-based studies, including a new consortium listed here. Now, I'll end by listing a few topics for discussion, including in particular multidisciplinary approaches and systems biology approaches that can incorporate Indigenous knowledge systems and processes that really deeply engage our communities in the long term to effectively develop, better understand, and address health disparities in those communities. I just want to mention briefly, mahalo to my talented team and looking forward to our discussions today. Mahalo nui.
Thank you, Dr. Mauna Kea. And so now for our final speaker, Dr. Park.
Hey, thank you so much for having me. Good morning and good afternoon. I'd like to thank NIMHD for this invitation to present on our efforts at the University of Hawaii Cancer Center in understanding the mechanisms that drive cancer disparities. I would also like to thank the other two speakers for providing such a comprehensive background so to make my life actually quite easy in what I'll be presenting today. Okay, so first, for this talk, so I'll be presenting some background on cancer, some examples specifically. And in these examples, I will show that there's evidence of biological differences in terms of cancer disparities. potential mechanisms that we are continuing to work on, and then gaps. And these are usually folded in within each example, as well as a discussion of the future directions. So first, a number of people who, if you have attended the determinants section, as well as here, that we've heard that there are a number of high incidence in cancer across the Native Hawaiian and Pacific Islander populations. And this is seen in breast, colorectal, endometrial, pancreatic, and lung. And these are just naming a few, but this is an example from the Hawaii Tumor Registry, where if you look here in the gray, that there is a persistence higher incidence of breast cancer in Native Hawaiians compared to the other racial ethnic groups in the common racial ethnic groups in Hawaii, as well as if you look at compared to the US population. And similarly, so here, this is in yellow, this is the Native Hawaiians, and this is for lung cancer. And we see that, again, this sort of higher incidence is persistent. And we've seen this throughout the 80s, again, using Hawaii Tumor Registry data. And if we're looking at cancer in US affiliated Pacific Islanders, you can see here that there are a number of cancers that are higher incidence, and that many of these are actually over 50% are preventable, mostly because they're related to tobacco, obesity, HPV, as well as betel nut use. So then showing these few sort of examples of the higher incidence does implicate some number of challenges that we may have to face, including multifactorial, because if we're looking at mechanisms, there is a huge social determinants of health, as well as lifestyle factors and health behaviors and environmental that may be contributing to this. So some of the work that we have done to really address in terms of breast, as well as lung, and then as well as obesity is can be shown. This is, so here we're first using Hawaii Tumor Registry data, and this is work done by Dr. Tapara, and I know that he's online. I saw him earlier. He found with colleagues that Hawaii Native Hawaiians have with prior, so this is ductal cell in situ diagnoses, have a higher risk of developing ipsilateral, so that's on the same breast, or contralateral, so on the opposite breast of where they the ductal cell in situ was identified. So having a second primary diagnosis of breast cancer when compared to white women. And that Filipino and Japanese women in Hawaii are at higher risk of developing ipsilateral. So it's just, but they were not seen to have contralateral. So this is suggesting that there may be biological differences, as well as other factors that may be driving these biological differences. Another example here, this is looking at TMA, so tissue microarrays of breast tumors. And this is looking at 787 invasive breast tumors. And here we see that if, here are the arrows. So in Native Hawaiians, so we don't see these in the other two groups, Japanese and whites, but in Native Hawaiians that there are some differences in terms of expression in the tumor. So we see that one, that Native Hawaiian, younger Native Hawaiian breast cancer patients seem to have a higher prevalence of tumors that are in the P53 mutation, and that those that have breast tumors from Native Hawaiians with advanced stage seem to have a higher percentage of expression in MDM2. So again, this is again suggesting that there may be biological differences, and this may be due to differences in exposure as well as other social determinants of health, and that more work needs to be done to understand what may be driving these molecular differences. In terms of some of the work to understand what may be driving these molecular differences, Dr. Maunakea had briefly touched upon utilization of the multi-ethnic cohort study. So this was funded by NCI in 1993, and it does include participants from both Hawaii as well as Los Angeles County, and there are over 200,000 men and women who were at the time of enrollment were 45 to 75 of age, and it comprises of these 5 primary racial ethnic groups as well as a few others. For the Native Hawaiians, there are over 13,000 Native Hawaiian participants, and then there's a smaller subset, about 4,000 with blood. So The advantage of using a data set such as this does allow us to disaggregate data as well as control for some known risk factors. So if we're thinking of in the earlier graph with lung cancer, that lung cancer was higher. So the higher risk, some people have questioned whether or not this is just purely due to smoking behavior, since smoking is a primary risk factor for lung cancer. And what we showed that is after you control for smoking, that really Native Hawaiians have a higher risk of lung cancer. It's similar to that of African Americans compared to European Americans, Japanese Americans, and Latinos. So then the question really becomes, what is really driving this? So the first attempt that we have looked at earlier was looking at internal smoking dose. So the idea being that, yes, maybe after controlling for self-reported smoking, could it be that when for each cigarette, they're getting more carcinogens as well as other toxicants? And what we do see is in African Americans, that hypothesis that is consistent with their higher risk, except however, with Native Hawaiians, we do not see that they have a higher level of internal smoking dose, which is not consistent with their high risk of disease. And when we looked at other smoking metabolites, what we really found was that it was just acrolein. That is higher in Native Hawaiians compared to the other racial ethnic groups that would be consistent with their directionality. And while this might help with understanding some of the mechanism, we are still, there's still some more questions because acrolein, while it is a lung toxicant, it is not a known lung carcinogen. Furthermore, we've looked at epigenetic, so this is DNA methylation, and we've looked at to see if basically smoking dose, so this is measured by TNE, influences DNA methylation in different ways across the populations. And we do see that indeed there are differences. So then these all these blue dots are statistically significant CPG sites that are showing differences in DNA methylation due to internal smoking dose. And what we see is a lower number of hits in Native Hawaiians, and that really may be due to a number of reasons. So this is where some of the gaps lie. It may be due to the fact that we are using commercial arrays that have been built using mostly white populations. And it may also be indicative that there may be other components that are influencing it that we're not able to see here. So the other angle that we have looked at in terms of trying to understand risk is that if we say small cell lung cancer, is much higher. There's an excess risk in Native Hawaiians to developing small cell lung cancer. And this is a much more aggressive lung cancer type. We also see that in earlier stages that the survival is lower. So we have been looking at trying to molecularly characterize lung tumors to see if there are differences in immune cell infiltration. And what we do see when these are all compared to whites, that there are clearly differences across the across racial ethnic groups. And this may help to understand what mechanisms may be driving the differences in terms of survival, as well as the type of histologic site that we observe. And lastly, I do want to present an example with coming to genetics of obesity in Native Hawaiians and Pacific Islanders. So this is a SNP that has been discovered in Samoans to be found associated with body mass index. And then later, utilizing the multi-ethnic cohort data, people did find that it was associated with BMI, obesity, and as well as some other phenotypes like such as hip circumference. And the two different dots, the colors, is showing what was basically genotyped. So this is using the commercial array, and this is imputed. So this is using sort of a reference panel to get the SNP. And that imputation has helped, although it does, this sort of becomes evidentiary support that better reference panels are needed in these populations that have been so understudied across time. And then I like to just summarize some other additional ongoing efforts. So I did not highlight today some of the work with structural racism, as well as other further molecular characterization in breast. But these are the works that are being done to look at both upstream and downstream factors in a multi-level approach. And as mentioned earlier by Dr. Mauna Kea, the new study to build a new cohort so that we can utilize a populomix approach. So in brief, really the future directions is really the need to build a more large, well-characterized population-based studies with both Native Hawaiians as well as Pacific Islanders in a way that builds trust and then provides us a strong foundation of resources so that we can study the social determinants of health, environmental interaction, exposures, as well as various other omics. This is epigenomics as well as genetics, and then also look at tumor markers for tailored therapy. And thank you.
Thank you, Dr. Park, and thank you to all of our speakers, Izua Maasi. So I'm going to turn it over now to Dr. Michael Spencer so that we can go ahead and begin the discussion portion.
Thank you so much. And thank you so much to the speakers. What a wonderful job giving us an overview of the mechanisms and processes. Now I'd like to begin by introducing our panelists. I'll start by introducing our first panelist and giving him an opportunity to begin our discussion. First panelist is Dr. Kalani Raphael, who is an adult nephrologist and a professor of internal medicine at the University of Utah and VA Salt Lake City healthcare system. He's a clinical researcher with a focus on management of chronic kidney disease associated with metabolic acidosis. Dr. Raphael is also the leader in the Native Hawaiian and Pacific Islander community and collaborates with community-based organizations to promote health and well-being in this population. Dr. Raphael?
Hi, Dr. Spencer. Thank you for including me in this very important event sponsored by NIMHD, and for just a fantastic set of talks that we just heard. A great diversity of approaches involving community-based work as well as epigenetics to really sort of get at some of the underpinnings of a variety of health disparities in the NHPI population. Yeah, so thank you for having me.
Mahalo. Our next discussant is Dr. Sheldon Rinklon, an associate professor in the Department of Family and Preventative Medicine, principal and co-investigator in the Office of Community Health and Research, and co-director for the Center for Pacific Islander Health at the University of Arkansas for Medical Sciences. His ongoing research interests focus on reducing health disparities by increasing patient-centered research with underrepresented Marshallese and other Pacific Islander immigrant communities. Dr. Rinklon?
Hi, Dr. Spencer. Yahweh, everyone. First, want to thank NMIHD for the opportunity and everyone with the chairs. I'm glad that I signed on from the beginning because it's been a powerful presentation, and it's amazing to see all the work and the people who are on this call who are doing the same things that all of us are kind of doing. Definitely been a learning experience from the beginning, and definitely with the last three speakers that had talked about different things. Did you want me to pose a question, or did you want to go and just introduce others first?
How about I go ahead and I'll introduce our last discussant, and then we'll
Excellent.
Thank you. Our last discussant, Dr. Tatine Satel, is the Chin Sik Hyun Suk Chung Endowed Chair in Public Health Studies and a professor in the Office of Public Health Studies at the University of Hawaii at Manoa. Dr. Satel is an internationally recognized scholar with over 25 years of research experience in understanding and addressing health inequities at individual, family, and community levels from a strengths-based perspective. Dr. Satel's work links analyses of health services and public health surveillance data with narrative perspectives and socio-ecological considerations. And particularly, one of her areas of expertise is health literacy. Dr. Satel?
Mahalo, aloha all. It is a tremendous honor to be with you all here today from the beautiful Manoa Valley on the island of Oahu, and part of this amazing event and this illustrious group of speakers and the assembled workshop group in the background. Mahalo to the conveners and the host, NIMHD, and to the wonderful speakers in this session. You guys did an amazing job really sharing with us deep understanding of mechanisms and processes. And much aloha to the discussant section group as well. I really look forward to talking And I really want to echo what Dr. Rilken just said. There's clearly an absolute critical need for additional work and funding and much to do. And it's wonderful to see the momentum represented in this event today. But I also really note how much this forum highlights how much tremendous work has been done by research community in collaboration over time across innovative funding, incredibly hard work, strong relationships to make these differences and to move our understanding of science in such significant ways already. And this is only the first day. So just really honored to be part of this and grateful to be here. Mahalo.
Mahalo. Dr. Raphael, would you like to start us off with some questions or some comments?
Sure. I was really impressed with your work, Dr. Mauna Kea, looking at the epigenetics of, diabetes and other factors. I'm from Hawaii, but, I live in Utah now, right? And, increasingly, the NHPI population is becoming, diaspora, right? I wonder if there's any evidence of, epigenetic changes that occur with, moving away from one's home, those sorts of things. Because, there's a huge population up here on the continent that, needs this attention as well. Yeah.
Mahalo, Kalani, for that question. I think that there's very little evidence out there right now to show that epigenetic changes happen as you for migration or when you go out of your own home area. But of course, the effects of the environment on epigenetic patterning and in one generation and the next can be influenced and carried over. And I think that relates more to acculturation. We do see similarly though, changes with the gut microbiome. So there's many other examples from other studies out there that show from immigrant populations coming to different, from their home countries to the US, and as they acclimate or they become more accultured, there's differences in diet, differences in experiences that they have that actually changes their gut microbiome diversity that relates to some of the health conditions. And so I bet we could probably see the same thing in Native Hawaiians moving from here to Hawaii. And then actually there's some examples from the MEC study in prior research showing that as you progress from, and there's populations from Japan, for example, that go from Japan to Hawaii and then Hawaii to the US. There's these linked cultural differences, and the severity of those cultural differences that happen relate to like the increased prevalence of certain conditions like cancer rates, for example. So there's likely epigenetic underpinnings of that change that manifests, and it would be nice to, form studies that we can actually combine or look at those changes as Native Hawaiians and even Pacific Islanders move away from Hawaii and other Pacific Islands to the continent. And link that to these, environmental social factors that might be influencing those increased rates of diseases that they might experience. In addition to that, though, I also want to highlight the potential resilience factors that we're starting to look at in terms of our own culture and retain and going back to some of our cultural practices, nutrition, lomi lomi, ho'oponopono, these other holistic approaches to healing and support well-being. We're really trying to understand how that actually can, reverse some of these deleterious alterations that send us onto this sort of poor health trajectory. So I think, it'd be good to have these kinds of studies that can show both these effects. Yeah, mahalo.
Would anybody else like to comment?
Actually, can I piggyback on that question by Dr. Raphael? And I think it's going to be for both Dr. Mauna Kea and Dr. Parkas. Definitely interesting stuff, especially with cancer and diabetes. And somebody who, has worked and lived in the Marshall Islands and now, then moved to Hawaii and now in Arkansas, the patients that I see when I'm back home are the same ones that I see here with the same chronic conditions. Diabetes, hypertension, cholesterol, but also cancer issues, right? And there's always been a question as far as how do we find ways to connect that to what has happened in the islands. Because we're in the Pacific and the islands, and with the history of nuclear weapons testing in the islands, that's always been a big concern among many other folks who are from Marshall Islands, but also surrounding Micronesia, and I'm not sure Hawaii as well. I mean, and we've done trying to figure out how do we make that connection. Is there some kind of DNA methylation that we can connect it to those 46 to 58 bombs, or because we know that there's high rates of diabetes, there's high rates of cancer things, kind of similar to what you've seen. Dr. Park mentioned about breast, lung, and colorectal cancer being high in the US API. Any thoughts as far as how can we use either the tumor registry or the cancer registry or any other methylation project that we can do, kind of look into that, if that's something that we need to look into?
I think this, thank you for the question, because I think it really underscores the importance of having the data, because I would say, the MEC multi-ethnic cohort data has been a very strong resource in showing that there are disparities that persist after adjusting for things that we know of, but then what is not there is we were unable at the time when we're collecting the data, and this is in part due to our knowledge, because in the 1990s we think of how much social determinants of health has grown, and that body of research. But so because of that, it's a need for actually more resources in terms of data components. I would guess that yes, there would be a signature for exposures that are environmental, but unfortunately, it comes down to sort of having a reference group, like something to compare it against. And right now we need to build that. And that is something that a lot of us on this panel, in this session, as well as in the other sessions, are aware of. So we've been trying to tap at that, but really what it is we need a study that is a resource that really captures the a sample size of Pacific Islanders as well. So we can capture the Marshallese in there.
I'll ask a follow-up question to that. How many people would you want to have in a study like this? What sort of sample size are we talking about here?
Oh, so so an example of if we use it from just our data itself for genetics, clearly 4,000 is good at detecting things. We could have some more. If we're talking about epigenetics, I know that there have been people have been able to detect findings. Like we also were able to find things with a few hundred, especially for things that are strong, very strong exposures. So something like smoking, something like other biomarkers, with water contamination. I think a few hundred would definitely be able to get at that. But at the same time, I think a very important component that everyone has mentioned earlier is really trust, because once we get there, then maybe the number, I don't even want to talk numbers until the trust is there, because then we're also getting maybe a different population that's willing to contribute to the samples. And what we need is to really have a broad spectrum that really represents the population. I think Dr. Holub was about to say something. She just went off mute.
Oh, thank you. Yeah, I was actually wanting to acknowledge Tanalavule's comment to everyone here in the chat about fast food making its way to our island nations, and thinking about the prior question about documenting changes. I want to agree and confirm that yes, we should document some of these changes. And in my work around physical activity, what I hear often is, at home, we have more opportunities to be physically active and have, fresh food. And here we just don't have, that same type of opportunity. And that was my original thought, but then also to Tana's point that, fast food is also making its way. I just wanted to sort of reiterate that point.
Mike, we have a couple other questions from the Q&A. It would now be a good time to go ahead and pose those.
Yeah, sure.
Okay, I suspect this is also for Dr. Park. So is there much research on cancer treatment and effectiveness of this treatment using traditional medicine and practices, either wholly as treatment or in conjunction with modern medical cancer treatments? And does your public health system or other health systems track these or other cancer treatments for cancer similar to traditional Chinese medicine? And then the second question, which I'll go ahead and throw out there too, is there danger in grouping Native Hawaiians and Pacific Islanders in epigenomic cancer diabetes studies?
Okay. So I guess the first question may be easier to answer in the sense that that would be excellent to include traditional medicine, but unfortunately at this time we have not. I could see that it would in conjunction use. It has been, people have found things to be effective in terms of physical activity. They have we have a researcher. This is not specific to Native Hawaiians. But they are looking at physical activity after cancer, during cancer treatment, and that has been shown to sort of reverse epigenetic aging. So I could see that if it was a physical activity that was culturally tailored and using culturally grounded research methods to be able to incorporate that, I think that would probably have, I could believe that having efficacy, but I would say that at this time there isn't, we're not there yet. And in terms of, sorry, the next question was, I think we've learned a lot from the disaggregation of data, and I would sort of emphasize that disaggregation would be useful. And then, as you can see from everyone's history, that it is quite different between, one group having colonization and another group having overthrowing, and while that results in both levels of cultural trauma, and there may be a unifying marker potentially for cultural trauma, which has not yet been studied, but I could see that it would be advantageous to disaggregate. But the question is now whether or not there is sufficient data out there.
I have a question. I would love to hear the thoughts of the panel. Major stakeholders here are healthcare systems and public health systems, and I am wondering the thoughts of the panel as those players as part of the process and mechanisms for the outcomes that you're discussing, including what we just heard actually as a place to count and capture some of this information, but also as addressing the upstream and downstream determinants as collaborators and partners, and then supporting this work generally. And I thought actually one of the areas I'm really interested in is the strength of social networks and stories. And Dr. Holub, I really agree with the way you framed those pieces as really part of the strength-based approach to addressing and moving forward together. And I wonder if we could start with you for your thoughts on that.
Yeah, absolutely. I think you identified a very important piece as far as healthcare and systems, and access to care is really important. But I think number one is who you can trust too. So I know trust comes up a lot, but that definitely applies. If the physician, looks like you, can understand and you can relate, it does make a huge difference. So I think in that sense, there's definitely a connection there, and a lot of work to be done. So even thinking about training and making sure we're developing the workforce in that way to help with that system. And
I guess I'll add to that too, if I may, about the system. So I do think that there's a lot of room to improve in our current healthcare system, especially along the lines of enabling prevention, which I think is the key actually to addressing health disparities. And in the research that we all do, I think the point is trying to identify avenues where we can stratify individuals for better improve our risk stratification for individuals that might be on a particular trajectory towards a particular condition, so that we can activate services and care, whether that be the traditional sort of conventional medical practice or culturally relevant care, to those individuals earlier, so that we can intervene and prevent those conditions from happening. And then tracking the efficacy of those interventions using the same biomarkers that we study that actually leads to those conditions in the first place. So I think there's still a lot more room for us to understand sort of the biological underpinnings of these health disparities so that we can improve our risk assessment and interventions, but then shift the healthcare system as well, not just for Native Hawaiian Pacific Islanders, but for everyone to move further upstream for and enabling preventative practices, which will get us to that state. I think that's where it needs to go. So that will, of course, involve a number of different things, from education, from research, from working with community in different ways, and especially meaningful engagement to be able to provide the support around understanding some of the ideology, which is very integrated. So we need a system in place that can allow for this type of interface of this, and remove silos and create a much more cohesive and comprehensive platform for improving health and wellness, which of course we have already talked about, inclusive of the upstream social determinants.
I have another one from the chat, and I think Dr. Park, you may have alluded to this or touched on it when you were answering the previous question. So this one asks, they're interested in whether there's epigenetic research being done which links, points to, or shows that racism, colonization, trauma can impact at a cellular level, like biological, or rather biological trauma caused by psychosocial trauma, like intergenerational, historic, etc.
So I would say actually Dr. Mauna Kea is doing a little bit of work where he is collecting data that will enable that. I could say from in a study that we have ongoing, so it's in its second year. We are focusing on looking at structural racism on a neighborhood level. So that does not necessarily touch upon the intergenerational as well as the on an individual level of historical trauma, but it does lead to areas that may have be subjected to having more structural racism measures. And then living in those areas have been shown in not just our data, but in other data, that it does lead to persistent sort of downstream effects, such as neighborhood disinvestment, as well as persistent poverty. So we plan to look at that in relation to epigenetics, but I think Dr. Mauna Kea might have some findings from his high seed.
Yeah, so actually just extending from what Dr. Park mentioned, looking at these neighborhood level socioeconomic factors that are result from that structural changes that relate to cultural trauma. I think we are starting to look at individuals that live in these neighborhoods that have multi-levels of adversities that affect aging at the biologic level, and we can actually measure that using epigenetic data. And in those cases, Native Hawaiian Pacific Islanders living in those neighborhoods tend to have an accelerated aging compared to what they should be chronologically. And that can lead, and as we see, that's linked to increased rates of obesity and diabetes and other conditions. So I think it's playing a role. But the other thing that we identify is that if we separate individuals, even within these poor socioeconomic neighborhoods, these areas of low neighborhood level socioeconomic status, for example, and we do look at the individual level for differences in education, other risk factors, other potential resilience factors, as well as risk factors, what we found is that those within those neighborhoods that have the higher education attainment, for example, and I kind of alluded to in my talk, have actually decreased accelerated aging. So there's less likely for this accelerated aging that's happening in those individuals. So it's sort of buffering against whatever is the contributors of this adverse neighborhood levels are doing to the individual level epigenetics. And we also see the same thing for diet, for health individuals that engage in healthier dietary factors, as well as other potential resilience factors that actually do have an effect at the epigenetic level. And so we're just starting to explore these relationships in our studies, but that really does take this sort of holistic approach in mind, keying in on not just the neighborhood level characteristics and built environment, but also really measuring what's happening at the individual level, which could actually bring us better information of some of the resilience factors that could be contributing to reduced effects on the trajectory of disease conditions. This is where I really hope that we can start concentrating more towards, because I think that has more resonance with our community and also implications to how we can improve the situation in our communities.
Thank you. Do our discussants have any other points they'd like to bring up?
I have a question for Dr. Ahola. You mentioned the importance of having conceptual frameworks that are culturally based. Could you just comment on how granular, do we need separate frameworks for different populations of NHPI, and then even factoring in like where they reside, like the continent versus Hawaii or Guam? Yeah, can you comment on that?
Yeah, no, absolutely. I alluded to, taking context into consideration. Hawaii, California, Utah, Arkansas. It is important to get as granular as you possible can, because it's important to ask, what are the stressors, what are the motivations, and figuring out that piece can help. But where we are starting to see more culturally relevant frameworks, but what we're also seeing are measures that are not working. So I think that's equally as important. And I know there's a session on that. I really look forward to that. I've been using some standard, stress scales, and it is not a good predictor. And so trying to figure out how we can, better understand and make culturally relevant measures, I think will also help us be able to build and validate and test some of these conceptual models. And originally I said adapted, and I thought, actually create, because a lot of these original theories are tested in mainstream populations a long time ago, and they really need to take into consideration context, location, and time. And so part of my work is post-pandemic, many might not want to receive health behavior interventions or preventions the same way that we did previously. Is it hybrid? Is it in person? Is it Zoom like we all are? So I think absolutely it's important to take in context, place and time.
Thank you.
We have something from the chat, so I'll just open it up to the whole group. Is there movement towards the development of an NHPI data repository similar to the NIH-funded Indigenous-led tribal data repository, or an NHPI-led biobank?
That's a great question. We've been working on this, talking to people at NIH, actually the Tribal Health Research Office, that actually does have some existing relationships with other Native American populations up on the continent that could provide some guidance into how we would create an NHPI data repository that protects Indigenous data sovereignty, as well as responsive to some of the needs in the community where this repository could be useful to address. So I think that's a work in progress. It would be great to have a broader discussion around this. And clearly that is going to be a need if we wanted to move towards this more holistic understanding of health and well-being.
I just piggyback on that. And, I think that's great. I know there was earlier in the other session, there was some question as far as, concrete recommendations to those that's on the call. And, I was thinking about that because, if we have to do this NHPI biobank or repository at the Tribal Health Research Office, I mean, it makes sense that we should have our own NHPI research office at NIH, doesn't it? So that it's run by us. We know we can lead it, we can run it, and we can focus on different groups who actually do the kind of work that we do. Because we've done all this, but instead of making it theirs, we should own it and have our own office of NHPI research in NIH. My suggestion.
You know, one of the questions that I did see in the chat from Dr. Lipule was this issue of building trust. I mean, a lot of this goes towards how do we build trust with our communities in order to collect this data. Definitely having an NHPI-led initiative would help with that. What are other ways in which we could build trust with community to collect this data?
And I think, that if we do that, I think that's one of the ways that we're going to build more trust among our people so they can be involved in more of the things that we're trying to do. And then, I think we just work with special populations. We have our different quirks. We have, similarities, but we have our differences. Sorry about that.
If I can start to take that one, as far as building trust, I did like the LEE acronym as far as listening, investing, and including as a place to start. And I know when I first began, I asked those initial questions. Not a lot of work had been done in San Diego. So what are the concerns of the community, but also how do you reach and what are the specific protocols? Because it's not always a cold knock on the door to say, do you want to take this survey? It's really, having a connection with community leaders, being introduced. And I think more and more, an important concept is just showing up. And I've found that just being there is really important. I've gotten calls to, oh, do you want to come to this event? And the next day, waking up early, I'm like, oh, should I go? Should I not? And every single time I go, I always meet and connect with more people. And I notice someone's like, oh, okay, that's your project, and just building trust. So, along with what we normally do in building trust and relationships, one of the things is also just showing up.
Yeah, but that has to go through all levels. I mean, not just an investigator to community interactions, but even the funding agencies as well. I think that's where I'm glad to have a conversation about this. And I think this is part of the workshop as well, is trying to figure out ways where we can actually have our communities understand who our partners are on the other end of the spectrum in an academic setting, and as well as how the processes look like from our perspective as community members doing research in community. I think having sort of that cohesion is really important. I mean, the trust building and just having, being present there is definitely critical, but it takes a lot of time and dedication and effort, and actually training and expertise around that and that support for that, which is not always there in our different academic spheres. And especially it's very different in kind of environment in the funding agencies and other stakeholders that are within that academic circle that our communities just don't understand or know how to approach. So I think having that type of cohesion and building trust beyond just the investigator community level is going to be part of this equation.
Well, and to link it also back to health systems, right? And public health systems and the capacity for providers and people doing health communications and other things to actually have the relationships, to have the conversation, to have the funding and time in the background, to have the deep conversations around what's meaningful to people for their health outcomes or for managing their diabetes or, for understanding a health issue in context to the things that they value and in context of their communities, as we talked around a lot of really critical models and considerations today. So how it all connects is exactly the thing, right? And so how we build the funding and time and capacity to do that, I think this is a really important moment for that. And so really appreciate this conversation.
I think we learned a new word today from the beginning, the LEE word, the L-I-I, like listening. This is our listening session now, right? So, this is where we're webbing out, that we're, conversing. And then investing, how do you invest? Invest in the new office, invest in the NHPI researchers and academicians and young researchers and advocates, and recruit and invest in our young people to carry out the work. And then in that way, then we're going to be including everybody that we're trying to serve. Lee.
And just to mention so that the wider audience is following, because I don't think they have access to the chat, but Val from our session 1 wanted to share that part of their building research capacity from the U24 and the R01 is that they've been collecting blood and plasma samples for ADRD genetics and biomarkers, and they're keeping a portion stored in American Samoa for future research. And then Paige also chimed in with a really interesting point that, you know, this behooves a lot of consideration given our various spaces that we occupy have varying political statuses, and what kind of standard data protection and privacy rights can be put in place and be applicable kind of across the board, so to ensure that kind of protection that all of our data and all of our specimens and the such require. I don't know if anybody wants to comment on that, because those are two really good comments that came up.
I can adjust the last point, if that's okay, just really quickly. That's something that we talk about a lot in our communities definitely need in order for us to not just earn the trust, but also to make an impact at the same time, because the data that we have, even within a research space, can be actually useful for supporting programs or helping navigate resources in the community level that could actually be relevant to health and well-being. So just sharing that data and being transparent about it, we created a process in order to be able to provide that back to participants from our studies that we collect samples and information from. So it's a real exchange of information and sharing on both the academic side as well as the community side. So that's not an obvious structure. It does take a lot of technical capacity and resourcing that kind of structure to provide this data portal. And we have other people on the group, other investigators that use this a similar approach in sharing this information to communities. But I think that's definitely just a standard requirement, you know, and we just have to build that out into our research going forward in order to maintain that trust, because that transparency is really important.
We have a couple of minutes left. If anyone would like to ask another question or make another comment.
Could you comment on the Asian American Native Hawaiian Pacific Islander cohort study and what the goals are there?
Is that for me? Sorry. Or Lonnie?
I think either one of you.
Well, the general goal is to better understand health and health disparities in our Native Hawaiian Pacific Islander communities. The goal is to observe what we can find in terms of risk factors, resilience factors that might be contributing to some of the long-term outcomes. The initial starting point is that we'll be building up a set of younger individuals than the multi-ethnic cohort provided, so that we can understand how, because we know that some of these conditions are occurring at an earlier state in our community. So it's important to go to that younger population. And then also to include more comprehensive data around the social determinants of health, as well as other types of information, biological data that we can generate that hadn't existed before, and build that resource for the not just our communities that are contributing, but the scientific community, so that we can integrate that data, create a broader data set that's covering more comprehensively the experiences of our community, to give us a much more better understanding of some of the protective and adverse factors that might be contributing to the onset of these conditions in our population. So I think that's really one of the goals. Of course, there's others, but one of the goals, at least as I see it, in our in that particular cohort. Lonnie, do you want to add anything?
It is a cohort. It's a cohort that will be built across 5 different sites. So there's a lot of strength to that, because it's focusing on underserved populations. So that's it's Asian Americans, including Asian Americans who have not been really studied in research. And the advantage there is that, one, we have various comparison groups that may have similar in terms of what people might think as disparities. But then I think the unique components are that there are, each group has their own different social determinants of health, and that might help to disentangle what may be just cultural versus like maybe a overarching just risk factor. That being said, it is only approximately 2,000 participants per group. So the goal is to get to 10,000 K, which that's it's definitely a huge endeavor. But at the same time, I think there are also, I think we would all agree that there needs to be other endeavors as well in order to address all the issues that may be.
I think we have time for one last chat question so we could squeeze in. Has there been any research looking at how food insecurity relates to epigenetic changes?
Yes, I'll take that briefly. Yes, we are engaging in trying to understand that question. We know that food insecurity is a contributing factor towards disparities, including diabetes disparities and other health conditions. And it does have an influence at the level of epigenetics through the gut microbiome. And that's what I was trying to allude in my talk today. So we know that changes to the gut microbiome actually are driven from dietary factors. Increased fiber intake, for example, increases the production of short-chain fatty acids, which is a anti-inflammatory factor that can contribute to reduced inflammation that associates with improvements and reduced risk for diabetes. So of course, food insecurity, which it's the opposite of that, where nutritious foods are not available, so that these other pathways are activated that lead towards increased prevalence of these conditions. So we expect that epigenetic processes are going to be related to that through regulation of inflammation that's mediated by the gut microbiome and diet. Sorry for the, maybe it's too confusing, but I can answer any other questions. Mahalo.
Thank you so much. And thank you so much for our discussants as well as our presenters. That was just a wonderful presentation. Learned so much about not just about conceptual frameworks, but also biogenetic markers and ways in which we might be able to even think about how we can prevent these diseases in the future. Thank you so much. I'm going to turn it back to Dr. Lai to take us into our break.
Thank you, Mike. So we're going to transition to our final session for the day. This is a breakout session. And the objective of this is to provide an additional and dedicated time to discuss more details about the specific topics at hand. So in brief, we're going to have 3 breakout groups. One will be the determinants and the mechanisms group, kind of like pulled together. The second will be on methodological approaches and tools. And the third will be on cultural interventions. For the determinants and mechanisms group, of course, this could be a natural place for not only those who presented and discussed, but for others if they wish to join, to be used as a discussion to follow up what was presented. And for the other 2, this could be used as an opportunity to discuss those unique methodological approaches or tools or interventions that could be used, considered in line with what was presented in these first 2 sessions. I really encourage all of you to join the groups and hopefully we'll have a relatively even number. This is for the speakers and discussants. And for the rest of our audience who's been joining us for the day, thank you so much for that and for all of your questions and comments. You also have the opportunity to join those breakout groups, again, in a listening mode, but you still with the opportunity to pose questions and provide comments. And I hope this is a wonderful time for you to just follow up with anything, just as we had to cut off Alika really quickly, and I'm sure there was a little bit more with his questions, for example. But this is just something that we hope and cherish that we can once we discuss this, we can bring this back again tomorrow. And just a reminder, we will meet. Our second day will start tomorrow at 1 p.m. Eastern time or 8 a.m. Hawaii time. And so just wanted to let you know about our starting moments. So now I'm just going to welcome everybody to transition over. We're going to give everybody a few minutes to transition over, and hopefully we can begin our conversation about 3 or 4 minutes. So I'll see you then. Thank you all. For those of us who've been magically returned to the main breakout room, again, want to thank you all for participating, and hopefully you all had a good opportunity to discuss. And I do welcome you to please join us again for our second day, for those of you who have not heard from me speak. But tomorrow we will resume for the second part of our workshop at 1 p.m. Eastern or 8 a.m. Hawaiian Standard Time. And with that, I will conclude our first day. Thank you again.